Genomind, personalized mental health through genetics. Mental health is biologically complex. Genomind uses genetic testing to move beyond trial and error, empowering clinicians with evidence-based insights to choose the most effective medications. Our testing evaluates how a patient's genes impact drug metabolism and response, leading to more confident prescribing and enhanced patient trust. While environment and therapy still matter, Genomind brings the power of genetics to your treatment plan. Genomind, empowering clinicians, improving lives. Brought to you by Caribbean Genetics.
Indus Life Sciences Private Limited, transforming human lives globally.
Aventa. Aventa evokes the word advance, reflecting our commitment to innovation and improving health across the region. At the heart of our logo is a spark, symbolizing the convergence of human values and science, because at Aventa, customers and patients are always at the center of what we do. So what's changing? Our pharmaceutical distribution companies in Jamaica, Barbados, Trinidad and Tobago will transition to this new name as part of our broader rebranding. Our retail operations at Superfarm, along with Linda's Bakery and Presto, M Pharmacy and Collins Pharmacy will retain their names, as well as our manufacturing companies Intersol and Carlisle Laboratories. Looking ahead, this rebranding strengthens our identity as one unified group, making it easier for us to grow, innovate and serve our communities. Together, we're advancing health, enhancing lives. Welcome to Aventa.
At Apex Radiology, we do more than just imaging. We provide answers, clarity, and peace of mind. We offer a full range of diagnostic imaging services, from X-rays to ultrasounds, CT scans, MRIs, mammograms, fluoroscopy, and interventional studies. We pride ourselves on accuracy and timely reporting because we know every answer matters. With locations in Kingston and Ocherius, our team is here to serve you with care and expertise. Call us at 876-292-APEX to book your scans today. Apex Radiology, the clear choice for all your diagnostic needs.
The future finds us faster than we think. But with CIBC Caribbean on your side, you'll be ready for all of it. That's how we've served Jamaica for over 100 years with industry-leading digital capabilities and innovative solutions. And it's how we'll do it for 100 more. That's the power of banking better together. Come, see what that looks like for you at CIBC. Ambitions made real.
Hello, good morning, everyone. Welcome to the JMDA's conference, When Care Meets Chaos, a post-hurricane reality. We're glad to have you guys. We have a very packed session planned for today. We're going to cover 3 topics in the morning session, and then we have an afternoon session as well, our second part session. So we have a lot to get through today. Before we go on, I want to take the time to remember all that has happened over the past year, and particularly the impact that Hurricane Melissa has had on the country, on our health infrastructure, or with our road infrastructure, our healthcare, or indeed the lives and livelihoods of our fellow countrymen as well. There's been a serious impact, and it has changed the paradigm of how we discuss things, and hopefully not for very long, but certainly for a significant time, we're going to have to make note of how to do things in a different way, how to help our fellow countrymen recover, those who have been impacted in the West, the less so in the East, and how to change certain aspects of the way we practice. So I think all of this happening, this conference happening now, is very timely to see how our care changes. And it's very beneficial for us all. The program is fairly packed, so we're going to move on ahead. We have our President's address coming up. But before we do that, let's take a moment of silence as we remember the doctors we've lost from our fraternity and the individuals who lost their lives due to Hurricane Melissa and her post-storm impact. Those we love don't go away. They walk beside us every day, unseen, unheard, but always near, still loved, still missed, very dear. Heavenly Father, we thank you for bringing us together today for this conference. We ask for your guidance, wisdom, and presence to fill our discussions and to help us listen with open minds and to speak with clarity and grace. Help us to make decisions that reflect your will. We pray for the presenters, the attendees, and the volunteers who made this conference possible. May this gathering be a source of inspiration, growth, and positive impact. In your name we pray. Amen. All right, thank you again for coming to our conference. A reminder that we have 5 CMEs, including 3 ethics and 2 mental health credits on offer. And without further ado, we'll hand over to our president, Dr. Renee Badro, for the president's address. Thank you.
Hi, good morning, everyone. Good morning. So this year marks a historic milestone for the Jamaica Medical Doctors Association. This year we commemorate 50 years of advocacy, service, and trade union excellence. Over the past 5 decades, the JMDA has advocated for fair labor rights, secured critical improvements in working conditions, defended doctors' rights, and led national discussions on health reform. Our achievements, from increased allowances and maternity benefits to ongoing industries tribunal proceedings, demonstrate the collective power of team leadership, of communion amongst each other. Throughout crises, including devastation caused by Hurricane Melissa, JMDA members demonstrated extraordinary resilience, serving communities while advocating for a safer and more equitable healthcare system. Today, I want to thank everyone for being a part of that journey, for joining this conference, for the many events that will be held for this year for our 50th anniversary. I want to say a special thank you to the sponsors, MPS, Medical Protection Society, Indus Life Sciences, our gold sponsors, Apex Radiology, Major Trust, Apotex, Arista Pharma, Aventa, to our silver sponsors, National Commercial Bank, CIBC, First Caribbean, Carrigen. Thank you all for making this first event of our 50th anniversary one to remember. And thank you, of course, to the team that was led by Dr. Jubilee Brown Service in the organization of this conference. Our organization has remained a steadfast voice for the doctors who keep Jamaica's health system functioning. And we just want to say thank you to everyone for being a part of our journey. Together, we will continue to strengthen the voice of Jamaica's medical professionals, and together we'll create a healthy system worthy of our country. Thank you everyone once again for joining, and most importantly, thanks to God for keeping us throughout 2025 and into 2026. I hope you guys enjoyed the conference. Thank you to all the speakers, and I know that they will give a presentation that will really cause you to stop, to think, and to wonder. Thank you, everyone.
Thank you, Renee. 50 years of advocacy on behalf of doctors, junior doctors, and then as the medical fraternity expanded to include some amount of senior doctors and junior doctors, the name changed to become the Jamaica Medical Doctors rather than Junior Doctors Association. But thank you very much. Now, we have a little bit of housekeeping to do. Again, we're confirming that your CME numbers are 5 hours, 3 ethics, 2 mental health. And we also have to acknowledge all our sponsors, our platinum sponsors, the Medical Protection Society, Indus Life Sciences, as well as our gold sponsors, Arista Pharma, Major, Apotex, Apex Radiology, Aventa, and our silver sponsors, Caribbean Genetics, CIBC Caribbean, and the National Commercial Bank, NCB. We are using the Teams platform this morning rather. You can type in your questions during the presentations. There will be a brief 5-minute question and answer period following each presentation. No need to retype questions. If you like a question, you can upvote them. We will monitor the chat for the questions. You can also have any general comments in the chat as well. We'd like the links provided in the various groups and emails and notices will describe how to pay for your CME credits. The Figaro link is provided. The conference attendance is, of course, free. We encourage everyone to share the link. For the CMEs, if you so desire, we ask for a contribution and you can pay via the Figaro link. CMEs will be distributed after the conference once we've confirmed payments. Please allow us 7 to 10 working days after the date of the conference to distribute CMEs and to reconcile all the payments. There's no need to post your email address or your name in the comments. We will work backwards from our Figaro payments. Recording of the conference and payment will be available until February 28th. So if you've missed the conference, or if you know someone who's missed the conference, you can send them the link up until February 28th. You can watch it, you can pay for it, you can get your CMEs. All right. I want to once again thank all our sponsors before we move on to a presentation by our gold sponsor, Magif Trust.
The land of wood and water, a country full of pride and world-changing achievements. We love, respect, and admire our doctors and all those in the medical profession who are first responders in emergency health crisis, and also those who selflessly and tirelessly work hard every day to provide premier healthcare to our nation's people. We salute you. The Medical Association of Jamaica Indemnity Fund, in partnership with Firm Insurance Brokers Limited, together presents Protecting Your Practice and Future, Insurance Here at Home.
Hello, my name is Dr. Andrew Manning. I'm an ear, nose, and throat surgeon based in Mandeville, Jamaica. I've been practicing medicine since July 1997. I've been a trustee of Magif since 2018. And I've been serving as a chairman of Magif Trust since around 2022. But what is Magif? Magif stands for the Medical Association of Jamaica Insurance/Indemnity Fund. Magif was born out of a need for local doctors to have their own locally based medical indemnity insurance. Years ago, the only medical indemnity providers were based overseas. And about 20 years ago, one of the main ones decided out of the blue to just leave. So we're left in a bit of a lurch. Magif started out with 20 MAJ members who came together and pooled funds, engaged with firm insurance brokers and a local attorney to provide for medical indemnity. Magif will provide for the medical indemnity needs of our clients. Our clients pay a premium and we provide medical indemnity insurance on an incurred basis. If you run into problems, you contact Magif and we will put you in touch with our attorney. One of the things I've noticed over the years as a practicing medical doctor and as a trustee of Magif, we're seeing more and more a need for doctors to have medical liability insurance. More and more persons in Jamaica are becoming more willing to sue. And you never know as a medical practitioner what will occur. And sometimes things will happen. Sometimes due to no fault of your own. And sometimes we might make a mistake. So we need to be covered, and Magif is the best avenue for you. We are here, we're a part of Jamaica's fabric. We are born out of the Medical Association of Jamaica, and we don't intend to leave Jamaica. So come on board. If you're not covered with malpractice insurance, you're putting yourself at potentially serious risk. So join us, come on board, and we will look after you.
Integrity, flexibility, and service is what distinguishes firm insurance brokers as premier providers of financial protection for you, those you love, and the legacy you have built. For over 25 years, Firm has continued the practice of offering fully integrated risk management services.
Hello everyone, my name is Desmond Johnson, Chairman and CEO of Firm Insurance Brokers Limited.
Hello, I am George Wright, Finance Manager of Firm Insurance Brokers Limited.
So Firm Insurance is a full service insurance company limited that offers general insurance, life insurance, and general insurance is property and public liability, any form of motor vehicle insurance. We offer that, plus pension fund management, trustee advisory, and consultancy for our clients and customers. We are able to do all of this because of our expert staff that has been here for years and are very professional in what they do.
Should you be unfortunate to be sued by one of your patients, Firm Insurance Brokers will be by your side. We'll provide you with the best legal support who will defend your rights for the best possible outcome. In addition to legal services, Firm Insurance Brokers through Major conducts regular risk management seminars. These seminars will assist you in protecting your practice with the knowledge of the best practices in the industry.
In addition to that, we do offer investment services and advisory. We'll help you with wealth creation strategy in how to diversify risk, invest for future wealth, and also for generational wealth. So in an investment strategy or wealth creation strategy, risk management is very important. To help the doctors and medical professionals in how you create wealth and mitigate against the depletion of wealth.
Become a member of the Magif Trust and protect your practice, protect your livelihood, and protect your reputation. Contact us today.
Thank you. So our next presentation, our first presentation, duty to care versus duty to self and the family. It'll be coming from Dr. Brian Charles. Dr. Charles graduated from the University of the West Indies, Cayville campus in 1989 with honors in pathology, gained his master's in 1994 and his doctorate in emergency medicine in 1995. He has subspecialized in hyperbaric medicine and has been involved in disaster medicine within CARICOM. He worked at the main hospital in Barbados as a consultant in the A&E department for 10 years, then the director of medical services for 1 year. He has been the Caribbean consultant for MPS since 2005. He was an associate lecturer in emergency medicine at the University of the West Indies and has presented widely on various topics related to medical legal issues. Dr. Charles was awarded the Silver Crown of Merit in 2008 and the Gold Award of Achievement in 2022 by the Government of Barbados for outstanding service to the profession. He's also an avid fitness enthusiast and follows the mantra that an ounce of prevention is worth a pound of cure. Very true. Please join me in welcoming Dr. Brian Charles for his presentation.
Thank you very much, Dr. Samuels. It's really a pleasure to be here again with you all. And this topic that you all chose, we didn't choose this topic. This topic is really, really vital. And I think I'm actually going to take this presentation to other medical associations because it is quite important. I want to say MPS is happy to be here, to be an integral part of your annual conference. And Renee, I didn't even know that you all were around for so long. So that's a fantastic legacy to continue. So my presentation today really speaks to duty to care versus duty to self. There's an error on the title slide. It says January 2026, but it's actually February the 1st, 2026. So if you look at I'm going to share my slides with you now. Let me pull that up. Yep, that's that. Right. So if you look at the two pictures on the shared slide, it shows two different individuals with two different outlooks. The first one at the top shows a doctor who is obviously very tired, very exhausted, and the one at the bottom shows one that seems to be satisfied. He looks happy. The one at the bottom is what we really want to achieve, and I'm hoping that by the end of this presentation, I'm only probably going to do 30-40 minutes to see if we can try to give you some guidelines as to where and why we need to aim towards there. Before we go on, I just want to remind you all that medical protection really is the world's leading protection organization for doctors and healthcare workers. We've been here for over 130 years. We've been in the Caribbean for a very long time, and we have and actually our head of business is located in Jamaica, and you would have known her. This is Ruth Russell Hutton, and I am the medical legal consultant for the Caribbean region, and we also have a business development executive in Trinidad. And between the three of us, we spread our wings all throughout the Caribbean to really offer protection that goes just not only when you're in trouble, but also to prevent things from happening and to encourage a safe practice. So our philosophy really is to support a safe practice in medicine and by preventing and averting problems before they occur. I have to disclose I'm an emergency physician, as you would have heard Dr. Samuel says. I'm also the NPS consultant. Now, because I like to have a fair amount of interaction in my presentations, I would like to encourage you all to each take out your smartphones. And if you can see this, scan this QR code on your smartphones to join me and join the presentation. If not, you can go to menti.com, menti.com, and enter the code 44892461. What that will do is that it will allow you to interact with us. There are several questions I want to ask of you, and it will interact with the entire conference. And we'll be able to share your views anonymously. And it brings the conference to life, basically. And I know that since COVID, we do these things virtually, but we've lost the face-to-face sort of interaction. This sort of engagement allows us to interact while we're doing these virtual presentations. So once again, if you can scan the QR code on your smartphones, if you can see it, or your tablets. If you are on a computer following the presentation, you can enter in your URL menti.com and enter, and it will ask you for a code, and our code is 44892461. So I see some of you have already joined, so I'm going to go ahead, and hopefully as we go on through the presentation, you will be able to interact. So the first thing I want to start you off, the first thing I want to ask you, just so you can get familiar with the format, is to vote what's your practice level. So you click on the result, and it will give us, and you can see this as well. I can see it, and we can see how we interact with each other. So we have a wide variety of practice. We have from medical students, house officers, senior house officers, most registrars, some consultants, and a couple of GPs. So that's good. My next question to you is, what is your practice discipline? So you can just type in, your practice discipline. Mine is emergency medicine. Wherever you are practicing right now. Not sure why this is someone says not applicable. I'm not sure why that's there. Primary care, ENT, family medicine. Okay, good. So we have some hospital medicine, and we have some primary medicine as well. That's very good. So this is interesting, because this presentation is not only geared towards hospital medicine, although you may hear me referring time and time again to maybe things that are happening on the wards or whatever, but it's applicable also to the primary care setting. So our learning outcomes today is to introduce what duty of care means, how it relates to us practicing, outline some of the risks that we face as doctors, and to make some recommendations for optimal work-life balance. So again, let's go into a case. And this is a real case, and I find it very useful to bring real life stories to the presentation so that we can relate to what I'm speaking about. So this is a story from a hospital right here in Barbados, our main hospital. And I encountered this when I was when I was a consultant in the emergency department. It is that of a 26-year-old doctor who graduated 4 years previously at the top of his class. I think he got honors in 3 disciplines, and he's now on his surgical rotation for the last 6 months, doing an on-call, 1 on every 3 days, and he plans to join the surgery DM program, but currently there were no vacancies available. So he's studying for his US MLEs to try to get a US placement. His last vacation was 9 months ago, and that time he had taken some time off to visit an alien relative overseas. So I want you, sorry, let's not go too fast. I want you to type in on your phones, on your devices, what do you think are the potential red flags in this case? List the potential red flags. So we have 1 volunteer working 1 in 3, last vacation quite a while ago, visiting alien relatives. Okay, and I'll come back to why visiting an alien relative is important. Vacation was not for rest and rejuvenated. That's exactly what I wanted to say. Yes. No vacation, overwork, conflicts, lack of time off. Okay, good. So whoever said poor work-life balance actually hit the nail on the head. And basically, this is not a story that is uncommon in our current in our current practices, because when we're young, we are career driven. We're working hard. We're working in situations where we are overworked, sometimes not getting as much time as we need to rest and recover, and we continue to drive ourselves, just as what you're seeing from this SHO. Basically, he's been working for 9 months straight. The last vacation he took was really not a vacation because he went to visit an alien relative, which obviously is a stressful environment. He is working 1 in 3, so he's on call for 24 hours. He still has his duties on the wards for the next 12 hours as the day goes by. And then he is back on call the next day. If you look at it, 1 in 3. So basically, it's really 1 day to do whatever he has to do. So you can imagine taking care of himself, looking after his home, his family, maybe some recreation if he can fit it in, getting some sleep. All of that is a very familiar circumstance that we all go through. Now, for me to speak to the duty of care, we really have to go all the way back to medical ethics. Now, remembering the title of the presentation is Duty of Care versus Duty of Self. So when we speak of medical ethics, ethics encompass the backbone of how we practice. It is the guide under which we have taken the Hippocratic Oath, whatever format you may have taken that oath. And it is very important to lay what we do every day within those ethical boundaries. So what I'm going to ask now is how many basic tenets of medical ethics are they? And you can choose, I think, only once. Please only choose once. I don't think I've limited it, but please only choose once. How many basic tenets of medical ethics are they? Okay, so you can see the spread, and I think the spread is going in the direction that we're asking for. Basically, there are four basic tenets of medical ethics. There are four basic tenets of medical ethics. Now, for those persons who said four, you all should get these right. What are these principles of medical ethics? And those who did not get it right, please, you can still give your principles and I will summarize them in the end. What are the principles of medical ethics? Okay, so the first respondee has it all correct. Somebody said four. Okay, that was for the previous, that's for the previous thing. Okay. Autonomy, beneficence, non-maleficence, and justice. All right. So to cut a long story short, that's it basically. Four principles of medical ethics, and it speaks to autonomy, beneficence, non-maleficence, and justice. And I'm going to explain all of these just very, very quickly. Autonomy means that your patient has the last say in whatever is to be happen to them, whatever procedure, whatever medication, what treatment, whatever you do, the patient should have the choice and have the last say in what's happening. Even though we think that we know what's best for the patient, we probably do.
I have a couple.
Someone is, pardon me? Okay, you can come back in when you're ready. So autonomy, the patient must be able to determine what is going to happen to him or her for themselves. That's the first thing. Second one, beneficence, always do good. Whatever you're doing, make sure you're doing good for the patient. Non-maleficence is do not do any harm. Never do any harm. So number two and number three are sort of similar, but they can be argued in a different way. And justice means that you should offer every patient, regardless of their background, their religion, their creed, their beliefs, their customs, you should offer them the same and the highest degree of care that you possibly can. And justice is also extended in that if the patient is aggrieved by what you have done, if you've made a mistake, then we should be empathetic and we should try to compensate them as much as we can. So those are the principles of medical ethics, and the duty of care is bound within that. So duty of care really is an obligation that we have that allows us to provide care that meets an acceptable standard, meaning that we have spent years in medical school, we have done our internships, we've done residency programs, we have experience, we have the academic knowledge. We know what the standards are. We need to be able to offer and practice at a level that does not go below that standard. Okay, so that's the duty of care that you have to offer your patient. And basically, it means that we must act in a way that all professionals would act in the same situation. So there is uniformity among our practice. So duty of care is a safeguard in that we should, whenever we are practicing, we should be practicing without any variation, or with minimal variation, I should say, in our practice. Also, it usually includes, and this is standard to all of us really, providing adequate treatment based on your knowledge, making a good decision when you're ordering tests and treatments and referrals, explaining what you think is wrong with the patient so that the patient can understand and be able to give consent for whatever you have to do. Remember that we said autonomy is one of the basic principles of ethics. Avoiding unnecessary harm and monitoring and following up whenever a patient's condition requires it to. So the duty of care begins whenever the doctor-patient relationship is formed, when a patient comes to you and says, I am doc, I'm not feeling well, I am seeking your help, your expertise to make me better. That is when duty of care started, right? And once you agree to treat that patient, you owe that patient that duty. Now, I'm not going to say much about negligence, but medical negligence there are three things that needs to be proven with medical negligence. The first one, interestingly, is that you breach the duty of care. The second one is that you fall beneath the standard of care. And the third one is that damages have occurred because of your care. So that shows how important it is for duty of care to be consistent and to be forefront in our minds when we are practicing. So if a doctor ignores the clear symptoms of a myocardial infarction that any other normal doctor would investigate, then the patient is harmed, you have a breach to the duty of care. So I'm hoping that this is clear, because it's the first part of our discussion where duty of care, we owe our patients that duty of care once they have come to us. So that should be absolutely clear at this point in time. If not, you can stop me and I will try to explain it some more. So let's continue with our case for Dr. B. So Dr. B is now coming off of one of his 1 in 3 on call. After post call runs and after a brief snack, he goes to the outpatient department. He's not on call. He was on call yesterday. It's the 12 hours after his call, and he's just gone to SOPD. He was just about to leave when he was summoned to the ward by the registrar of the on-call team for that day, informing him of a deterioration of one of his surgical ICU patients and that they are heading to operating theater in 15 minutes. Question for you. What should Dr. B do? And you can type in, a few words, a phrase or so, what you think Dr. B should do. And I reiterate, 1 in 3, he's just come off call, he's just had a snack, he's headed to SOP, to surgical outpatient clinic, he's finished his clinic, he's on his way home, and the registrar has informed him that his patient on SICU has deteriorated, they're going to surgery. What should he do? There's no wrong answer or right answer, but I want to hear from you all what you think he should do. Someone says he should resign. That's very funny. Someone says go to surgery like a good doctor. Okay. Now, these responses are all what I'm thinking of would have gone through all our minds in a similar situation. Dr. B has had now up to 36 hours when he has had no rest. He is tired. He's barely had something to eat. He's just gone through SOPD. His care to his patient, which remember I spoke to of duty of care to his patient has now deteriorated. He is going to feel as though he is obligated to continue that duty of care. However, my next question, I should have put this on the other slide, on another slide, is if he goes with go to operating theater and treats that patient, do you think he's going to be in a good frame of mind to treat that patient safely? And then my next question, on the other hand, is if he leaves and goes home, do you think he has breached his duty of care to that patient? The answers to both of these two lines is that I don't think that he can manage this patient safely if he goes to operating theater in such a situation. Bearing in mind that I do understand his obligation and he knows his patient and he may feel obligated to go and continue the care for that patient. But if, as some of you rightly said, he referred that he would ask the registrar or explain to the registrar, look, I am 36 hours now at this hospital. I cannot perform as I should. Please continue management. I will take over from you tomorrow morning, which is the right thing to do, and nobody's going to fault him for that. Okay, I know Dr. B, may feel that this is not what he should do, but that is the right way for him to do it. On the other hand, if he goes home with just saying, look, I'm tired, I cannot do anything, and just goes like that, then there is a feeling he may experience some feelings of guilt that he has not done as much as he should or he could. right? So this is the dilemma that much of us face when we discuss duty of care versus duty of self. So this is a good time to segue into the next part of the presentation, duty of self. So duty of self is a term that is used to describe responsibility to look after your own health and your well-being. It is not a legal or a professional term, but it's something that we use frequently in medical and legal psychology, where we ask ourselves, are you taking care of yourself so that you can offer the best quality service to the patients that you care? And it usually includes things like, if you're ill, seek help and seek advice, following good treatment plans. And we all know the worst patient are doctors. All right. So, duty of self, ask yourself to please follow the advice of colleagues who are involved in your health care and your treatment. Being honest about your symptoms and history, avoid harmful behaviors when you know the risk. Now, when I was researching this topic, I came about a study that showed that up to 30 to 40% of doctors who are ill still report to work. And even with illnesses that are potentially contagious, viral flu, some persons who have migraines, who things that they cannot focus, or they have a risk to the patients, they still report to work. And I was saying to myself, I didn't realize it was so high that doctors do not give the best to their patients. And remember the ethics or principle of ethics about non-malfeasance. This is definitely one that's against that principle. So if you are ill, you should not be working, because you will not be doing a safe practice and good justice to your patients. And what could happen is that if we are frequently neglecting our duty of self, that could lead to burnout. And the ICD-11 2019 edition defines burnout, and I will read for you, as an occupational phenomenon. And this is an important thing: is occupational phenomenon resulting from chronic workplace stress that has not been managed effectively or successfully. So if you neglect duty of self, and if your organization neglects duty to you, then you have a risk of burnout, and it could result in energy depletion and exhaustion, feelings of negativity, cynicisms, reduced professional efficacy. The last one there is of concern to me as a medical legal consultant, because if you are not practicing safely, your patient errors are going to happen, and your patients are going to have harm, and then lawsuits are going to follow. So the relevance of this topic comes right back here to duty of self. So for those of you who may have heard of burnout but not familiar with exactly what the symptoms are, these are some of the symptoms, and I will allow you to read them out. There are four major categories of symptoms of burnout. These include emotional, where you could be angry, stressed, irritable; cognitive, poor concentration, showing resistance to change, and even resistance to have input into your practice. It could be behavioral, where you show differences in how you are accustomed of working. And of course, the physical symptoms, lethargy, increased sleep disorders, etc. Be aware and be cognizant of the fact that this is not depression. Okay, so I want to stress on that. Though these symptoms of burnout overlap with symptoms of depression, these symptoms of burnout are workplace related. So these persons who exhibit these symptoms can leave and work well at home. They're fine with their families, they're fine in their social environments. But when it comes to coming back into the workplace, then these things manifest. And this is the danger, really, because doctors with burnout report bad attitudes and behaviors that, again, are not safe. They keep inaccurate records. They do not discuss options of treatment with patients or within the team. And they don't, they're not fully working as a team player. They make errors. And interestingly, and Bay in the study in 2017 showed that they also feel guilty about how they treat their patients. So burnout is a real thing, and it's very important. It affects the cognitive functions such as memory and decision making, less empathy to their patients. The teamwork is not as good as it should be, and it impacts the quality of care, showing more errors and more harm to patients, just as I mentioned earlier. And there are many studies that show this. So remember what the last question we asked about, well, what should Dr. B do when his patient got ill or deteriorated? Are you in this super doctor trap? Now, I'll tell you from experience that in my younger career, I felt that I could do everything, anything, all the time while at work. And it was like, the alpha male, go, 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 do. You're in the emergency department, you're seeing all the trauma cases, you're helping out with the non-trauma cases, you're rushing to do intubations, you're doing cardioversions, you're doing everything that you possibly can, but at what cost? Right? That's the question that we will need to ask ourselves. At what cost? I know we said that, and we always say your patient comes first. But if you're doing this by working excessive hours, your entire life is consumed by your work. You're not reporting for sick if you're ill, and you have that mentality that dedication is more important than your outcome, then you're in the super doctor trap. And you need to be very, very careful of the super doctor trap, because though you may think that it helps with your career development and it helps with how your colleagues and the professionals see you, the cost of it really is not going to be good. So what we need to do is to balance duty of care with duty of self. And there are organizational interventions that we can do. And I know many of us are not in an administrative position that we can impact these organizational interventions, but it's important to know that burnout is an organizational issue, and that anything that needs to address it must start from an administrative point of view. So a positive workplace environment can help us promoting calm at work. I'll give you another interesting story. So I work on an air ambulance as well, and I travel all the world to transfer ill patients from one jurisdiction to another jurisdiction. And the environments that I see where there is the most calm are the happier environments, where the team works better, where the patients seem to be more enthused at being at, and you would be surprised, a chaotic emergency department does not augur well with good healthcare. Although, in our situations, in our environments, with so many patients, so many ill patients, so few doctors and so few nurses, needless to say, poor and inadequate equipment, we may not be at the optimal place to have a calm environment at work. But the studies have shown that promoting calm at work is a good thing to avoid burnout. Civility, simple things like saying please and saying thank you to your team members is something that would help to augur good or decrease burnout. Gratitude, celebrating achievements. And the last thing is something that I wasn't really familiar with until I started to research this, was that if you do 20% of your work in an area that you are happy and you like, then the risk of burnout reduces by up to 75%. So for example, when I was in the emergency department as a registrar, senior house officer and registrar, I liked trauma. So I used to deviate down to all the trauma cases because that's what I liked. And it is found that there are other persons who may not like trauma. They may like infectious disease, or they may like, the cardiac cases. If you spend 20% of your work time doing something in an area that you like, your risk of burnout decreases by 75 to 80%. I found that very interesting. So that was the organizational thing. The tips for you as an individual now for duty of self is to oscillate between performance and recovery. Performance being when you are working, recovery being when you can sit back and recharge. I'm not sure if any of you are tennis fans, but persons who perform at a very high professional level, and I refer to the tennis players, you would see most tennis players have a ritual. And have you ever asked yourself why between the points do they all do this ritual? And Rafa Nadal is probably the one that does this the best to me. He has a ritual that if you look at him for 5 matches, you actually can rehearse, you know what that his ritual is. And that is what he does between his performing when he's playing and his recovering, where he blanks out everything and resets his mind. The psychology is that we should try to oscillate between performance, where we are working hard, and recovery, when we do something where we shut off. If it means that after every half an hour, we stop and we take a 5 minute breather, we shut our eyes, we count to 100, we breathe, anything like that. But oscillate between recovery and performance. That's a good tip as an individual. Say no for safety. Dr. B, in the case that we said before, should say no to the registrar who's saying he's going to operate in theater. No, I cannot come and assist in OT right now. Can you do it? And I will take over in the morning. All right. So that's saying no for safety. Live with less than perfect. Again, I remember when I used to do apply plaster of Paris for trauma, fractures and stuff. I used to try my best to get the POPs as smooth as possible so that the patients could write on them and draw on them and stuff. But you know what? That extra 20% of the time that you spent smoothing out is not going to make a difference to the fracture. And your aim was to treat the patient, right? So the aesthetic value where you wasted, extra 20% of your time making it perfect has absolutely no benefit to you nor the patient. Learn to delegate responsibility if you're in an administrative position, recover and recover well. So I was asking, okay, some persons have already started the answering. What do you do to recover? And please let me know what some of you all do to recover. Sleep, visit family or friends, anything else? Anyone exercises, go to movies, eat, travel? Yeah. Right. So it's important to have a portion of your life that is dedicated to recovery. Excuse me. And this is important. So I want to end here by saying that we try at Medical Protection to avert problems before they happen, and we do so by doing webinars like this. We have learning on demand. We have a new app that's very interesting, where you can learn on the go, and so we have fact sheets, and all of this is available as as a member from MPS. Part of what we're going to do is, and I want you all to make note of this slide, and Ruth will make it available for you, is that we're having some webinars in February and March, what we call well-being webinars. The first one is how to stop the slide into burnout, which I'm sure relates almost relates to what we've just said regarding to duty of care and duty of self, how to support your colleagues and how to manage yourself and stay resilient during a complaint. So with that, I want to thank you again for having us, Medical Protection, present to you JMDA for this very important topic. And I think I have some time that I can take some questions. If not, please have the questions emailed to us and we will be able to answer them, and we promise to get back to you as long as you send us your questions. So thank you very much for your attention and your participation. And these three graphics show exactly what we're trying to achieve. Look at the faces of those persons. This is how I would like you to be. Thank you.
Thank you very much, Doc, for your presentation. It was very, very enlightening. I especially like the Menti, the interactive, live interactive component. Very, very nice.
Yes.
We do have time for questions, as he was saying. You can post your questions in the chat, please, so we can go through. There is a question comment here by Dr. Gordon, O'Shea Gordon. He says, if the system is broken and the only choice is a 36-hour tired doctor or nothing, isn't it the duty of care to turn back? So it's either a tired doctor or no one at all. So what choice do you have?
So my advice to you, and this is of recent, remember that what I spoke about, the super doctor trap, where you are tired, you're working 1 in 3, you have limited staff, you have limited time to take care of yourself. But remember that even if you are tired and fatigued, and we know we have a duty of care to the patient, if we overextend ourselves, we are not doing that patient any good. And I would go back to the basics, go back to the ethics, right? Non-malfeasance. So if you cannot practice, your administrator is saying, listen, I need you to cover this. I need you to cover this. We have patients coming in. I know you were 1 in 3, even 1 in 2, whatever. You have to be able to say no for comfort and no for safety. And you'll be surprised, even if you stand up for this and explain, listen, I cannot perform and I do not want to cause any harm to my patient, then they would understand. Because forcing someone to work, especially in a intensive sort of environment where there is risk, that's not good.
All right, thank you for that. Just another question. Suppose someone does work in that situation, they make a medical error of some sort. Is that a mitigating factor? Can they then point to say, listen, I was 36 hours, I've got 40 patients. This error, I was the only one there. Is that a mitigating factor in case of litigation?
Nope. No, it isn't. Because the judge is going to say to you, you had a duty of care to that patient, and you breached that duty of care by working in a substandard environment and doing a substandard medical procedure or medical practice. The right thing to do, or the righter thing to do, was to have referred that patient where they could have gotten better care, and hence the beneficence part comes in. Do good, always do good. No, I understand all of what I go through it. I know what we speak of in terms of resource challenges. However, you have to realize that if we take risk and something goes wrong, it is going to be worse for you as an individual. And it's no mitigation against litigation if you say, well, look, I worked 1 in 3. I saw 40 patients in SOPD, and I still had to go to theater, and I forgot the swab. I did a swab count. I swear I did a swab count, but I was so tired I missed the swab. Nobody's going to side you. Nobody's going to be on your side. Okay, so there's no excuse for that.
All right, thank you. Is there Are there any more questions in the chat? I'm looking, I don't see anything right now. All right, if there are no other questions, Doc, you can always email MPS if you come up with questions later. And as Dr. Charles has said, there's a list of future conferences and dates that will be shared. I don't know if he wants to bring it back up one last time.
Yes, let me show that to you, because that is quite a. Let me share that with you all again. Right. Make a note of it, and I'm going to, and Ruth is going to send this to you all too, Ruth is going to send this to you all. The first one is next Wednesday, and the next webinar. And these are international. We have international resource persons to do these webinars, and I can guarantee you that they're really good. Try to make yourself available for all three of these webinars. And you don't have to pay anything extra. It's included as members. They're there for you.
All right. Thank you again, Dr. Charles, for an excellent presentation. We're going to move on to a brief video and then continue on with the rest of our program.
How are you today? My name is Ruth Russell Hutton, and I'm the Business Development Manager for the Medical Protection for the Caribbean and Bermuda. It's an honor and a privilege to be here sharing with you today, and I want to share some pertinent information about my organization, Medical Protection. Now, MPS, Medical Protection, is the world's leading protection organization for doctors and healthcare professionals. We are a non-for-profit, it's a mutual. So once you join, you become part owner. And we are here to protect and support the professional interests of more than 300,000 members globally across the Commonwealth. Membership with us provides access to expert advice and support, along with the right to request indemnity for complaints or claims arising from your professional practice. And our philosophy is pretty similar to what a lot of our grandmothers brought us up by saying, to practice safe medicine by helping to avert the problems in the first place. Of course, grandma would have said an ounce of prevention is better than a pound of cure. Very much the same. So we're here to protect your career, your reputation, and your financial security for both medical and dental. Just as a FYI, we have the umbrella organization, which is Medical Protection Society, under which we have medical protection for doctors and dental protection for dentists. Same features and benefits, the only difference is the type of membership, as I had stated or differentiated before. Now, we have been in the Caribbean for quite a while, and we have a global footprint all across the Commonwealth. But at this moment, I'd like for us to just pause for a few seconds out of respect for our fallen colleague, Andrew Bromfield. Some of you may already know, but Andrew passed September last year. Thank you. Members of Medical Protection, you would have received a notification last year of this. So I still want to share with you also the rest of the team. We have Stephen Joseph based in Trinidad, and we have Dr. Brian Charles, our consultant, who is based in Barbados. So how do we support you? Now, there are two forms, claims and non-claims. And sometimes the non-claims cost more and take longer than a claim would do. And I'll explain to you. We provide legal support in matters such as disciplinary matters. You're brought up before your consultant, the head of the department, the medical council, the Ministry of Health, to explain, to prepare a report based on your professional work, of course. And if you're in membership, it's a matter of reaching out to us, and we're there to provide you with the support. A lawyer will be provided for you through the legal team here in Jamaica. And they prepare you, they coach you, and of course, attend and speak on your behalf. We provide legal support for criminal investigations, because I like to think of it as those pesky, not so pesky, coroner's inquests that can take a lot of time. We spoke about the medical council investigations. We provide medical legal advice 24/7, 365. We have a dedicated toll-free number for members in Jamaica to access for medical legal advice, as well as for membership queries. We have a confidential counseling service that's available through a third party. And if you're interested in accessing this service, simply go onto our website and search for well-being. As a member with medical protection, you're entitled to up to 6 sessions at no cost. We provide tons of risk management resources that are available on our website again and our members portal called Prism, and help with unwanted media attention. You know, your name ends up in the 7 o'clock news on CVM or TVJ, Dr. So-and-so, da-da-da-da-da-da, and you're thinking, oh my God, how did this happen? And your first thought is, let me pick up the phone and, yeah, we say pick up the phone, yeah, but pick up the phone and call our press room. The press room is open 24/7, 365, and they're there to help you to prepare a statement, to even post a statement on your behalf, pending on the situation. Now, the claims, the biggie, clinical negligence. If you get that big brown envelope saying that you're being sued for clinical negligence, then it's time to reach out to us as well. And full support is provided for you, providing, of course, that we fit into all the parameters. One of the good things about MPS is that we offer, it's not an insurance product, it's discretionary, and a lot of times we do apply discretion to assist members, and that makes things that much easier for us and for you as well, because with a policy, you know, you have exclusions, it's all black and white, they'll do 1, 1, 1, 1, 2, 2, 2, 2, nothing apart from that. But for us, all the weird and wonderful things that can crop up in medicine, we can apply discretion most of the times to provide assistance to members. Note the words 270 million Jamaican dollars. That's the maximum liability per individual, per claim, per incident, claim or incident per year. Yes. That's how much you are protected. That's how much you are covered. So if you're interested, I have the QR code up. I'd love for you to scan the QR code. Note, medical students membership for you is at no cost. Interns and house officers, membership is for free for the first 2 years. Thereafter, you will be asked to make an annual subscription. Consultants, you know the importance of having the need of having indemnity, both in every space, in all the spaces that you can find yourself. So we do invite you to join. A quick thing though, you may be thinking, oh, but I already have an insurance policy. I'll have to wait another year or 6 months or whenever until that policy ends. Nuh-uh. Switching from a claims made, which is the insurance policy, to medical protections occurrence-based, you may think it may present a challenge. But what we're saying is, when you end your policy with the insurance, it ends any cover that you would have had for the time that you were practicing. So say you you've started with an insurance company and the policy covered you from January 1 2020, December 31st, 2026. If you end that policy, there's no more cover for you, even for that period, that 1 year, in most instances. And unless you get what they call a tail, that's extra money you have to pay to cover for it, you're going to be at a loss. Now, taking into consideration that a claim can occur years after the treatment, any gap in your membership or your coverage or your subscription can be a concern. So if the necessary arrangements are not put in place, you're going to be exposed to potential legal defense costs and damages arising from something that happened 2, 3, 4 years down the road. So here's how we provide support for that. We have a product called Retroactive Reporting Benefits, RRBs, or nose cover. Now, what that does, it means that if you work in private practice, you can apply to us for RRBs, giving you a fixed 5-year period of protection. So that means we're taking on 5 years worth of risk in the past for you. So that means not only will you enjoy the benefits of medical protection membership throughout your career, when you've signed up, into your future career, but you will also receive comprehensive protection for any claims and medical legal matters arising from your previous work for 5 years. That's a good thing, eh? So again, we invite you to join us if you have any questions, any queries. Those of you who are in membership, please note, it is extraordinarily important that we hold current, accurate details of you, your telephone numbers, your email address, place of work, scope of work, time of work. We need to know. If we don't know, then we're not able to provide you with the kind of service that you need. Also, please, let me come closer to the screen. Check your emails, check your emails regularly. Don't allow your membership to be automatically canceled because of non-payments, because you missed an email, you missed several email reminders, 3, 4 of them piling up over a 4-month, 3-month period. So with Andrew post out, you will be seeing notifications coming to you from one of 2 emails. It's Caribbean and Bermuda, with the word "and" spelled out, Caribbean and Bermuda at medicalprotection.org. Or you may see international.applications@medicalprotection.org. Check your spam. If either of those emails end up in the spam, save them so that future emails won't end up in the spam. They'll go into your regular inbox. Either way, take a quick search and look, because who knows, you might just find some very important information hanging in one of those inboxes from us, from one of these 2 emails. And last but not least, if you have any other questions, queries, concerns, or you weren't able to scan the QR code, give me a call. There's my telephone number. My email address is there. Feel free to reach out to me at any point in time. So, as I said, we're here to support you. We're here to help you to avoid the problems before they begin. And it is central that we just keep in touch. So take advantage of the benefits that we have. Let us know if your scope of work has changed, your time of work. Let us know if your email has changed. Respond to our emails. This is the way we communicate with you, where we let you know about events, conferences, opportunities. Let's stay in touch. With that, I say thank you for your time, and do have a wonderful rest of this webinar. Thank you.
Thank you very much. So just going through a bit of our housekeeping again to remind you of our sponsors. We've heard from our platinum sponsor, Medical Protection Society. We also have Indus Life Sciences as our platinum sponsor. Our gold sponsors include Magid, Arista Pharma, Apotex, Apex Radiology, and Aventa. And our silver sponsors are Caribbean Genetics, NCB, and CIBC Caribbean. You'll see in the chat a link, if you didn't see it before, for the figure of payment. Right, there have been some reports of people having difficulty registering and joining the meeting. So you'll see a link as well for the meeting. You can share it with those who are having any difficulty. to register. I'm also briefly including the meeting ID and the passcode for you to share for those who are interested. Okay. All right. So just a reminder, we're just a bit through the first session of our 2-session meeting. We have 5 CMEs on offer, so we're going to have another brief video from Majib before we introduce our next speaker. All right, thank you. I have the pleasure of introducing our next speaker, Dr. Zinshu Adeli, who's going to be presenting to us on altered standards of care and risk mitigation post-disasters. Dr. Adeli is a medical doctor and attorney at law whose career spans clinical medicine, medical ethics, ophthalmology, and legal advocacy. She's a graduate of the University of the West Indies and holds degrees in basic medical sciences, medicine and surgery, law, an honors degree, as well as legal education certificates from the Norman Manley Law School. She also has a postgraduate diploma in ophthalmology with distinction from the University of Plymouth in London. Dr. Adeli currently practices as a medical ophthalmologist at the Old Harbour Optical Center, where she specializes in non-surgical management of eye diseases, advanced diagnostics, and patient-centered medication. Alongside her clinical work, she maintains an active legal practice as a sole practitioner, focusing on civil litigation, conveyancing, probate, corporate law, and adoption matters. Her leadership extends to health innovation as managing director of Jackson Limited, where she spearheads the transformation of traditional multi-site healthcare delivery into a modern web-based ecosystem. Hello, good day.
Hi, can anyone hear me? Can you hear me?
All right, I do apologize for that. There was a brief interruption in power. The downfalls, the pitfalls of going virtual in a modern economy. So just to continue, we were introducing Dr. Adeli. We had mentioned, of course, that she's managing director of Jackson. which spearheads the transformation of healthcare into a more digital setting. She's also served in multiple senior medical roles across Jamaica, including work in general practice, ophthalmology, and minor surgery. She's a respected voice in the national discourse, and as such, she's a frequent guest columnist for The Gleaner, where she writes on issues related to public health, medical ethics, patients' rights, adoption laws, and social policy. She's presented widely on ethical issues, including at the Association of Consultant Physicians of Jamaica, at multiple ethics and mental health symposiums, at the Western Regional Health Authority Ethics Symposium, and at the University of the West Indies Faculty of Medical Sciences Annual Research Conference. Her talks explore complex themes such as patient autonomy, ethical boundaries in clinical care, and real-world dilemmas in medical decision-making. Dr. Lee's multidisciplinary expertise uniquely positions her at the intersection of healthcare, law, and ethics, right? So I'd like to welcome her as she presents to us on altered standards of care and risk mitigation post-disaster.
Thank you so much. Are you able to hear me?
Yes, we can hear you clearly.
Okay, wonderful. And you're able to see my presentation? Yes?
Yes, we can hear you. We can see the
And you
presentation.
can see. Thank you so much. All right, so I just want to thank the Jamaica Medical Doctor Association for inviting me to approach this topic, and I really do hope that it's beneficial to everyone who is present here. Thank you so much for that introduction. It's the best introduction I've ever heard. I wish I had a recording of it. And it actually gives me somewhat of, kind of like an imposter syndrome, like who is that person you're talking about? But I really appreciate it. All right, so our topic here now is altered standards of care and risk mitigation post-disaster, right? And in the spirit of risk mitigation, I am just going to proceed firstly with my legal disclaimer. So this presentation is for educational and informational purposes only. It does not constitute legal advice. No attorney-client relationship is created. And as we would have understood before, that means there's no relationship as to duty of care. The attendees should consult qualified legal counsel regarding their specific legal questions or situations. So that is me leading by example. All right. So this presentation becomes relevant in the wake of Hurricane Melissa, which would have affected Jamaica in October of 2025, for those of you who are present and perhaps maybe live under a rock. Now, the medical legal landscape in Jamaica would have shifted to accommodate extreme pressures on the healthcare system, right? And for those who are practicing in this post-disaster environment, there is a balance that you have to strike between the urgent care with the limited resources and the requirements of medical licensing as it pertains to each person's perhaps to volunteer, as well as the liability that remains in force. So in continuing to talk a little bit, in continuing to lay a little bit of background information, I wanted to just touch on some relevant legislation that would have kind of, that would be important in this post-disaster period or during the disaster period as well. So the Disaster Risk and Management Act is kind of the umbrella law that grants the Prime Minister, the Minister of Health, ODPEM, extraordinary powers in order to kind of bypass these delays that you would have had if you had to go through the normal channels. So it's a kind of a state of an emergency where we're able to act very quickly, do certain things without having to go through the administrative process, right? And the aim of this is to protect the public's health. So, for instance, Section 26 of the Act would have allowed the minister to declare an area or the country as a disaster zone. And as a result of that, it would empower authorities authorized officers to do certain things, and relevant to medical doctors would be such as enter a place which in the declared area without a warrant and take equipment or personnel or materials needed to protect the public health. And under Section 2 of this Act, you would recognize that authorized officers includes medical officers, nurses, public officers employed to the government, right? Then we look at the Public Health Act, which of course is always in force, and we should always be aware of what it is saying. But we think of it especially with the reporting responsibilities that we have for reportable diseases. And of course, post Melissa, when we had this high surge in leptospirosis, we know that we had this kind of reporting responsibility, and failing to report can actually lead to a criminal punishment, right? So then we look at the Medical Act and the Nursing and Midwives Act. Now, this becomes important because we need to recognize that even though we may be in this kind of post-disaster period and we have maybe some sort of disaster. Let's say that you were on vacation, you came into the country, you're a doctor, you're a nurse, and you really want to jump into action. Not because we're in a disaster means that the licensing that is required by our act all of a sudden disappears. It certainly still remains in force. You cannot act as a doctor or a nurse or any other healthcare professional in our country without being properly licensed. However, it does now empower emergency credentialing, right? So instead of going through the normal channels and, the various waiting periods and vetting periods, you can actually get emergency credentialing, registration, and be able to now act in that capacity. But it's very important that you don't bypass this process, right? And of course, when a zone is declared as a disaster zone, it's very important for you to now listen out for these emergency orders that are going to be given out through the various channels, usually through your regional health authority, coming down to you, and it will determine how you have to act in this period. Now, what can happen is you end up, some of these orders can, you end up working out of your usual hours, before you were hired to a nice clinic, living a quiet life. All of a sudden, you're at KPH A&E or you're in Black River somewhere, and it's all a part of it, right? Because under Section 9.2A of the schedule of the disaster risk management, we know that a public officer can actually be required to respond and assist anywhere, right? You can be redeployed across different parishes, which is not usually how your contract works. And as well as you can be asked to provide care in non-traditional clinic settings like the shelters, the field hospitals, and so on, right? So your scope of practice kind of changes and can change, especially for those who are in that affected area. So what is your medical legal risk? What do you need to keep at the forefront of your mind as you're operating in this kind of altered reality? This is not how you usually practice. Your scope of practice has changed, right? So while we're in this disaster period, it might alter the kind of standards of care that you're used to, and that can be expected. However, you have exposure, you still will have exposure in certain areas, even during this disaster period. And I want to go through them with you right now. This is the meat of the matter of what we're getting into here. So negligence, right? We need to understand that, oh, one of my slides are missing. Okay, I wonder why. All right, so negligence is the standard of care based on the judgment expected of a reasonable, competent medical practitioner in the same circumstances, right? So, of course, we know before, we were just told in the last presentation that you must owe a duty of care, right? And that is established once you have that doctor-patient relationship, right? There must be a breach to the applicable standard of care, and it must cause some kind of foreseeable harm, right? So we must understand that it is contextual, and I think that's important, especially when we're talking about this disaster period. It's circumstance sensitive. What are the circumstances of the situation that led to this foreseeable harm? It's fact specific. So no two people, have the same facts. And so we need to know exactly what happened, what took place in that particular situation, right? And so the question is, what would a reasonable doctor have done faced with the same constraints, the same risks, and the same information available to them, right? Okay, so now we have to just kind of orient ourselves to this disaster condition. So we know that there's going to be widespread damage to hospitals, clinics, roads, utilities. You may or may not have them, right? Such as loss of electricity, potable water. Obviously, sanitation is going to be affected. And you may not be able to communicate for very long periods, as we would have experienced, right? Shortages of staff because persons cannot make it, right? Medical supplies could have been destroyed, and of course, no more is coming in. So whatever you have, you may do. Medications and equipment destroyed, displaced. Then we know that, shelters could be overcrowded. And then you have makeshift treatment facilities where facilities were damaged. And of course, now you have this increased prevalence of trauma, infectious disease, and certainly an increase in public health risks, right? So this is the contextual kind of lowering of expectations. You certainly cannot expect of me to give you the same kind of service and the same standard of care in this situation after the disaster that you would have gotten before the disaster, or in another setting where all of these things do not exist. So we can't expect that of anyone, and certainly the law does not, right? So you have limited diagnostic tools, right? So a diagnosis can be made without imaging, right? You can't follow the ideal clinical guidelines. You can't do serial X-ray, serial CBC, and all of that. So treatment may have to be given, without the full investigation, and that may very well be justifiable, right? Now you're into this triage-based kind of decision making. So you are prioritizing your care based on the severity of the injury, trying to save as many lives as possible. And then, of course, you may have this kind of delay or impossibility of referral, right? So you have to kind of just stabilize the person and really, truly cannot offer definitive care for the situation that you have in front of you, right? So now there's a shift to, okay, the optimal care, to more of a reasonable care in this kind of disaster. So it's, this is the best possible care. And now we're saying you need to still provide reasonable care, reasonable, right? This is the lowest standard of care that you are allowed to give. It must be reasonable. So it allows for deviation from the standard protocols, as I was saying before. You can end up having to use alternative treatments, as well as your documentation may be modified, right? Your consent procedures are going to be modified in this situation because you may, you could have been having a computer system. There is no computer. Your paper system, all of the files are away. What are we going to do, right? So we need to know that these things may be modified and it can be reasonable, right? But this deviation really needs to be rational, right? You can't now, as a physician, act irrationally in the situation, right? It needs to be proportionate, right? You can't have something just completely, out of the realm of what we consider to be, proportionate to what you're facing. And it needs to be defensible. Now, if it is rational, usually it is defensible. And you need to be able to link it directly to the disaster constraints. So you can't say, look, I didn't treat this lady's blood pressure because we were in a disaster and that's a chronic illness and I didn't think it was important for me to treat it. No, no, no. What if the blood pressure medication was very much there? You need to know what is actually available to you and what is not. You can't make assumptions because that's not defensible at all. So we know that you are going to now kind of be in this kind of triage kind of situation where you want to save the greatest number of lives. You need to allocate scarce resources. You need to prioritize based on urgency and survivability. And if you have a poor outcome, it may not establish negligence if the decision was reasonable and if you followed accepted disaster response principles. All right? So what will be asked of you is what were the resources that were available at the time? What were these risks foreseeable? Right? And I wanted to say, so we went into this resource thing. It's very important that you do not convince yourself that if you are in a disaster situation, you get to act a certain way. No, you must be aware. Is the ultrasound machine working? Is the X-ray machine working? You must seek it out and be careful to be able to document the X-ray machine was not available. Not that you did not look for it, because you still have to keep in your mind what is the best practice. And only after you're unable to offer that best practice can you step it down to the next best thing. I don't have that available, so the next best thing is this. We can't drop the standard and use it as an excuse then. We must be able to prove. And we, of course, were these risks foreseeable? For instance, you send a patient to, get an operation in an operating theater and a dog jump out and bite them. That's not foreseeable. I mean, who would have expected a dog in the operating theater? So not everything that happens to the patient can be really pinned on you. It must be something that a reasonable person would foresee happening to the patient, right? And did you document and explain the constraints to the person? It's very important, right? Because you can't go back in time 10 years later. Court move very slow, So 10 years later, the judge is not going to believe you when you say, no, man, this is how they go judge. This is how it goes. No, 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 no. You need to make sure you document it. That documentation must be contemporaneous, because it cannot be after your lawyer go coach you for say this. A joke, lawyers don't coach clients. But it cannot be after this, the fact, when you know you're in trouble, that you're going to now start reporting all kind of things were wrong. It must be documented. So be very careful to keep that level head and get everything documented one way or another. All right. So we're still talking about this kind of negligence thing, right? And in this disaster period, what you call that thing when you're excited? In the fight or flight response. Anyway, you guys can't even respond to me, so I don't know why I'm asking. But you know, when you're very adrenaline, Lord have mercy. So when you have this kind of adrenaline going through you, and you know, you have the best of intentions, you want to jump in there and you want to save everybody. You may very well kind of jump out of your, you know, what you're usually used to doing, right? So I want to say very clearly, it's very important that you practice within your training experience and your registration, whatever you're registered as, right? You know, if you are a nurse, don't start to do all kind of doctor things, right? And if you are a dermatologist, don't jump into the obstetrics all of a sudden because we're in a disaster. That is not how it goes, right? So avoid taking procedures that you are not competent to perform. As mentioned before, there's no excuse for it. You need to know where your limits lie, right? So I wanted to point out this case, and I'm going to start a YouTube channel just to discuss these cases, and this is a Jamaican case, right? This case is the case of Right and Goodapety. I hope I'm pronouncing that correctly. It's actually a general practitioner who was kind of trying to treat an ophthalmic disease, and he had the wrong diagnosis. He wasn't treating it properly, and the patient lost their sight. I hope I'm quoting the facts properly, right? So the court actually found that the doctor was negligent, right? He lacked the requisite knowledge and skills for this treatment, and he failed to adequately advise and arrange appropriate care for this patient, right? And it was no defense for him to say, I'm a GP and I have to just do the best that I can do as a GP for this patient, because guess what? The best you can do for this patient as a GP at the time would be to refer the patient to somebody who is more competent and exposed and experienced to actually treat what you see in front of you. You must recognize your limits and you must practice within them, right? So no hero procedures. Don't all of a sudden be placing an airway, chest tube, you're doing fasciotomy, you don't even remember where the fascia was. Because way down in an internship, that's the last time you go see one fasciotomy, and this is 15 years later, you don't know what you're doing, right? Don't all of a sudden decide you're going to be doing a C-section, right? Support that patient best as you can, but C-section may not be for you, right? So if this procedure exceeds your competence, you are exposed. If it can be established that safer alternatives existed, you can be exposed. And if your documentation fails to show that it truly was an emergency, right? So there can be certain exceptions. Okay, fine, you are the only person. There's nobody else, right? This person, there's no phone, nobody to transfer to, and this person is unstable. This person has actually gone into cardiac arrest. Well, they're going to die. And maybe if you intervened at that point, then the thing is, you really didn't do any harm. They were in cardiac arrest. So if you try to do an airway in a patient who literally flatline, that's a whole different thing. But you must document it. And you cannot tell us after the fact that the patient had flatlined before. We must see it right then and there. Patient flatline, this is what I did. Okay? So you have to keep those things in mind when we are just really wanting to do our best and everything that we can do, right? All right, so let's get into now informed consent. So this is another area of exposure, and certainly post-disaster, everything is kind of muddled. You don't have everything available to you. That nice little pre-done informed consent form that you're used to, we don't know where it is. Where is it? I don't know. So you are now forced to now kind of be offering medical services without these tools that were put in place to protect you, right? But you're still liable. So this is a this is a quote I took from a case, and I want to say that the actual case I got it from is also a Jamaican case, Octavia Chambers. So in the case of Sidway and Board of Governors of Bethlehem Royal Hospital and Maudsley Hospital, as you can see there in front of you, the judge opined this when he was speaking about informed consent. So let us orient ourselves around what informed consent is, right? So an adult person, right, that has capacity, right? Adult person of sound mind is a person with capacity who is entitled to decide which, if any, of any available forms of treatment to undergo, and is entitled, right? So, and her consent must be obtained before let me start over. An adult person of sound mind is entitled to decide which, if any, of the available forms of treatment to undergo, and her consent must be obtained before treatment interfering with her bodily integrity is undertaken. This is autonomy. The doctor is therefore under duty to take reasonable care to ensure that the patient is aware of any material risk involved in any recommended treatment and of any reasonable alternative or variant treatments. And I want to add here, you need to let them know what, if anything, is the course if no intervention is taken at all. So they can make a decision as to whether they want to do nothing at all. The test of materiality is whether, in the circumstances of the particular case, circumstance specific, a reasonable person in the patient's position would be likely to attach significance to the risk. Not whether or not you think it's significant, because you cannot measure what is more important to the patient. A patient might want to keep their leg and go home to the Lord full with all their limbs, and you may think it's better for them to live than to lose their limbs. So you're not telling them of that possibility. That's not how it goes. It must be based on the patient's perspective, right? And as well as the doctor should reasonably be aware that the particular patient would likely attach significance to it, right? So this is kind of what the gold standard of consent is. This is the gold standard, right? Now, is this altered? Is this altered? Is a disaster? You cannot ask someone. My head can't even think straight. What are you talking about? There's 10 people here, the water coming in right here, so, and I need to just get this patient the care that they need to get. And so, when I have no time for this, you know what I mean? I don't have any time for this, right? So let us get into it to see if it is, sorry, let me not lose my place on my thing here. Where am I? Oh my gosh. I apologize. Where am I? Oh no, lost it. Okay, I'm going to find it. Negligence. Okay, I apologize. Let's go to the next slide. All right. So informed consent is actually going to remain required unless the patient lacks decision-making capacity, right? If there's a true emergency where a delay would threaten life or serious harm, and where there's no next of kin available, because remember, informed consent can come from a next of kin, and the disasters kind of narrow, but it does not eliminate this duty, right? And this is the way that it narrows it, right? So it narrows it in saying, okay, if there's an immediate threat, no capacity, no next of kin, and you just don't have the time and it's an emergency, right? So this is what my slides are mixed up. So this is what I wanted to come to, right? You're in an emergency, you don't know what to do, you know what to do, and you just need a patient to just hurry up and give me this consent so I can move on. So you're like, look here, this is your only option. If you want to live, you have to go do this. right? No, but we can't do it. We cannot help you unless you sign this paper, sign it right now. You know, this is an absolute red flag. Don't make the mistake of losing your composure and trying to coerce a quick consent from the patient. This is certainly going to be, you are going to be liable. It is going to be as if the patient did not consent, because if consent is not consent unless it is informed. And so you would be liable for medical battery in that case, right? So now, what kind of protection do you have in these emergency situations? Are you actually protected? I think so. I think so, right? So in the case of F and West Berkshire Health Authority, it says here, a quote from the judge is, it says here, it seems to me to be axiomatic that the treatment which is necessary to preserve the life, health, or well-being of a patient may lawfully be given without consent, right? This doesn't need any explanation. The patient was going to die. You know, they're on the operating theater bleeding out, and I really had to remove that uterus, or I had to take out that liver. That is what I saw, and I had to do it. I can't wake this patient up to ask. Goes without saying, right? Also in the case of Montgomery and Lancashire Health Board, the law lords actually held that the doctor is excused from conferring with a patient in circumstances of necessity. As for example, where the patient requires treatment, but they're unconscious or otherwise unable to make a decision. So you have to make sure that you can document why this patient was unable to make that decision and why you took that decision. Must show that it is an emergency and that the patient was not capable, right? Now, I also wanted to speak to when you're transferring a patient, right? Because let us say you do have the ability to transfer the patient is not able to give you consent. What do? Who is going to sign this consent? This patient, you don't know who this patient is. Them have no ID on them. Them not conscious, so them can't tell you nothing. And you need to go. Now, I actually found this, and I think that it was very difficult for me to find this. Searched on the internet, right? So I just knew something, that it existed, right? This is actually a Ministry of Health Policy and Procedure manual for referral and transfer of patients. If I was doing a question near, I would ask, and you can put it in the chat. Do you or have you ever heard of this document? Have you read this document? Anyway, it actually says here in section 3.2 that in the case where a patient is unknown or unconscious and there's no next of kin, the consultant making the referral or the SMO should sign the consent form. Not that they should give verbal consent. They should sign the consent form. And not only that, it says here, so they should sign. And I want you to see, if you are the consultant or the senior medical officer signing this consent, it's very important for you to document for your own self the status of this patient and why you are signing the consent on behalf of this patient, right? So this is what happens in this kind of emergency situation, in this kind of disaster situation, right? And these are things that court might use to assess, okay? So you need to assess it for yourself. Is the patient capable of decision making? This is an adult of sound mind, right? If it's not an adult of sound mind, where's the next of kin? Because they're going to have to make the decision. If there's no next of kin, is it the SMO or the consultant that should sign this form? And if that is not possible, okay, is this a truly emergent situation? What are these material risks that I'm supposed to really tell this patient about in this situation now, right? And remember, you must document. You must document it, okay? So this is how, it's going to be altered. It's going to be altered. We're not going to get the full fee, but you still have to protect yourself, right? So what you're going to do, you can use kind of abbreviated, but explicit consent. You can put, you don't have to say, we have an x-ray machine, this, that. Okay, the resources, they are limited, very limited resources. These are the risks associated with what you have to do. These are the alternatives that we have available. You need to make sure that you are telling the patient about what limitations exist. You need to make sure that you documented some sort of capacity assessment, whether or not this is an adult of sound mind, where's the next of kin, so on and so forth, as well as document why. And, I kind of went through this, so let me not go through it again. All right, so the next thing that is important is going to be the breaches of confidentiality. So we're in a disaster. You can still be held negligent. You still can be held for medical battery if you do not get reliable consent, as well as you still can be held for breaches of confidentiality, right? Data privacy especially. So becomes relevant as well. So we owe this continuing duty of confidentiality to the patients, even in disasters. All right, but in a disaster now, everything is chaotic. We don't know where these patient records are. They might be thrown out. You sometimes you just really have to go around, you write something on a piece of paper, you tack it right here. So, and you say, okay. And then, of course, you're using whatever communication channel is available to you. And for the most part, a lot of people use WhatsApp. It's like, okay, let me just send this to you. You can do this x-ray for this patient, 94 years old with blah, 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 blah. Okay, but guess what? If this patient becomes aware of that and has a problem with it, you might very well be liable for breaches of that patient's confidentiality. All right, so you can't share patient information, of course, with the media, right? And one of the things, I mean, I really feel like I don't have to go through this because doctors know they can't share patient information with the media. They know that they can't disclose sensitive data, without some sort of legal authority, right? But sometimes I wondered where some of these images came from that I saw during this post-disaster. And I wonder if some of our medical doctors who were on the scene were providing this kind of imagery. Even if you're at the hospital and you're like, whoa, the roof I dropped down, da, 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 da. You can't video the patient in the hospital and send it to the media like that. You cannot. You cannot do it. That's a breach, right? So think of the Kobe Bryant example, right? First responders on the scene, taking pictures, sending them, sharing it with the media. No, that's a breach. That's a breach of confidentiality or a duty of care to keep that patient's confidence. You understand? So I wanted to point that out, especially as we think about the post-disaster and how we can really not thinking about our duty of care. It's very different for a random person to shoot a video and, put it up there. Them not necessarily owe no duty of care to this person. But you as a doctor, you owe one, right? So permitted disclosures, of course, fall under the Public Health Act, where you do have to report notifiable diseases and share relevant patient data with all the public health authorities that are authorized and other public health physicians and so on. So you have to be able to facilitate referrals and so on. So you are protected that kind of way. All right. So here is some practical advice, right? If you must deviate, you need to document it, and it needs to be a contemporaneous note. And I went into that, so I don't want to belabor a point, right? this is kind of like a why note, and it needs to be there, right? So for instance, you're suturing somebody, you have no anesthetic, standard local anesthetic unavailable due to Hurricane Melissa supply chain disruption, procedure performed without anesthetic to prevent exsanguination, right? And then if you don't have the formal dockets for the patients, maintain some sort of logbook. Make sure you have some kind of time record, as well as you need to keep it safe, right? Because you still have to make sure that you're not breaching confidentiality. Keep it safe, whether or not it's on some encrypted device or whatever. You need to keep it safe, and make sure you're able to look at it to know what had influenced your major decisions that you take, right? Now, consent, as we said, could be modified. If it is a verbal consent, very much I think you need to have some witnesses, and you need to document that somewhere. So you have your little log, you write out your thing, and you say, you know what, the consent was verbal in the presence of nurse Senua Daly and this volunteer who was there, Rayon Anderson, right? And you document that you got verbal consent from the witness, the patient. Sorry, I'm mixing up my terminologies between yes. So, and then of course you have this kind of stabilization only rule, right? Where you kind of limit your interventions to only what is necessary to stabilize the patient. This is kind of where I'm saying don't do anything out of your area of expertise. You kind of try to stabilize. You want to defer elective or complex procedures. And this actually also speaks to, like, even when you're consenting, you know what I mean? Try to, I would say, really try to don't do too much when you're in the excitement or the rush of a real full emergency. Stabilize, and then when you are able to now think a little bit more clearly, you can do a proper consent and protect yourself, right? So those are the things that really stood out to me when I was looking at what kind of medical legal risks are still going to exist for physicians and how are you going to mitigate it. So I really hope that that was helpful for you. Now, other things that I really, just the things that kind of came across when I was doing my research and kind of popped into my head as a Jamaican Medical Doctors Association, I wanted to mention to you guys, things that you certainly need to, I don't know if you already have, but let me just mention it. So you need to think about, like, the occupational safety of the doctors of your association. You need to make sure that the workplace is actually safe, that the necessary information is being provided, that they make sure that you're not forcing doctors to work in unsafe areas. This is post-disaster, so they need to know, okay, is it that I'm going to, is this a safe environment, or am I exposing the doctor now to unsafe areas? And then you need to make sure that you protect them, right? Now, of course, these are essential services that you're providing, so you're going to have to turn up, and you have this kind of compulsory attendance. So even if you're a hospital blow away, you need to turn up to work. But where are you going to turn up to work? There's no hospital gone. So you need to find out, okay, where is it that this person is going to attend, and hopefully maybe you can establish that beforehand so they know, this is where the emergency operating center is, and that's where you're gonna show up, right? As well as compensation, it's so important, right? We know that as doctors you can be required to work in extra hours and so on, right? And yes, in emergency, certainly as doctors, I don't think any doctor really has like an issue with turning up and doing their job and being there to help and to, maintain public health as much as they can. but they should be compensated, right? They should be compensated. And so you need to have some sort of something in place to say, okay, these are the extra duties that are going to be given out. This is how much it should be, as well as there should be a special inducement or hardship allowance. I know that it does exist in some shape or form, but certainly there needs to be something in place that, if you're forcing me to come to work in a hospital where I am going to now have to do the job of 4 different people because, or I have to walk, park my car out there or no car at all, or walk from here to there, I'm going to need a little bit more compensation. I don't think that is unfair. I think that is how we should be treating people, even though morally and ethically we are expected to do it. I do think that compensation is still a fair expectation. So, in conclusion, post-disaster medical practice in Jamaica operates within an altered but not abandoned legal framework. The standard of care remains context sensitive, judged against what a reasonable practitioner would do under disaster conditions. So exposure persists in critical areas such as gross negligence, practicing beyond your competence, failures of informed consent, and breaches of confidentiality. And of course, you must comply with these mandatory disease reporting obligations. Oh, also, you can check out my website, consult the doc. It's still under construction, but that's my little project for that I'm working on to build that ecosystem.
Okay, thank you very much, Dr. Adeli, on your very timely presentation, given all that has happened recently. We are going to allow the members of the audience to formulate some questions for you. We have one so far, but in the interim, we're going to get a message from our gold sponsor, Apotex, and afterwards we'll jump right into our question and answer section.
Statins are HMG CoA reductase inhibitors used to lower lipid levels and reduce the risk of cardiovascular disease, including myocardial infarction and stroke. They are considered the gold standard for high cholesterol treatment. According to the American College of Cardiology and American Heart Association in 2018, statins are considered first-line treatment options for dyslipidemia after lifestyle adjustments do not result in desired therapeutic response. The increasing use of this class of drug is largely attributed to the rise in cardiovascular disease in many countries. Statins also possess pleiotropic properties, including improved endothelial function, reduced inflammation at the site of coronary plaque, inhibition of platelet aggregation, and anticoagulant effects. Apotex can be considered the statin hub, as we have 4 of the most effective statins in treating dyslipidemia. We have our apopravastatin, aposimvastatin, and our superstatins, apoatorvastatin and aporasuvastatin. The ability to evaluate patient outcomes while taking statins is crucial to their treatment. Therefore, lipid levels should be checked 1 to 3 months after starting statins. Based on the importance of monitoring dyslipidemia patients, the Statin Lipid Test Patient Support Program was introduced. Any patient who is prescribed one of our 4 statins for 3 months is eligible for a free lipid test. This free lipid test is done through a simple voucher system. Here's how it works. First, a doctor issues a voucher to the patient, which is then taken to the pharmacy and endorsed. Once the medication is dispensed,
The completed voucher and requisition form can be taken to any participating lab to have the lipid test done. The voucher and requisition form are the only currency needed at the labs which are available island-wide. It's a seamless process designed to help monitor their cholesterol levels and enhance their heart health management.
Why should you choose Apple? 1, you're assured of a high quality. Our products are formulated to contain the same active ingredients and to produce the same beneficial effects as the originator they replicate. 2, you get affordability. Our products are at a price point that patients can afford. 3, accessibility. Our products are well distributed in all pharmacies island-wide. And 4, our therapeutic range. We have a wide range of products in numerous strengths and forms. So please, remember, when you choose Apple for your patients, they're receiving a high-quality, affordable pharmaceutical option. Have an Apple-tastic day.
Okay, there is a brief spotlight question, 2 spotlight questions by Apotex in the chat. They say the first 2 people with the correct answer will win a prize. There will be 2 questions. So the first question, what is the minimum amount of time a person should be on apostatin before utilizing the free lipid profile test? I'm seeing some answers already. Question 2, what are the 2 items needed to claim the lipid test? So question 1, what is the minimum amount of time a person should be on an apostatin before utilizing the free lipid profile test? And the chat has Dr. Fitz-Henley commenting at 1 month. I don't know if Abigail here wants to unmute herself. And Dr. Wilson commenting 3 months. Those are the first 2 responses. And question 2, what are the 2 items needed to claim this lipid test? Dr. Fitz-Henley says the claim form filled out by their doctor. Dr. McFarlane, Sandra Lee McFarlane, says a requisition form and voucher. Based on the records of the chat, I think question 1 might have been answered by Dr. Fitz-Henley. Can we have a confirmation? And question 2 by Dr. McFarlane, Sandra Lee McFarlane. So we'll record those names and we'll contact you through Apple, on behalf of Apple, for the prize. Can we get a mention of what the prize is that they may have won? We'll have Apple. We'll announce the prize as soon as Apple gets back to us, but we'll move on to our questions for Dr. Ade Lee. I hope I'm not butchering your name.
No, that's okay. I think you may have pronounced that first name incorrectly. It's Sinew.
Sinew. All right. Thank you.
Yes. No problem.
All right. Our first question for you. There's some concern by Dr. Richard Shaw. How do we define who is the next of kin by law?
Okay, yes. Under the Mental Health Act in Section 3, we have kind of a definition for relative, right? And it's under this act that we learn about, mental capacity and not being able to consent for yourself as an adult, right? So it goes in order. So the first person to contact as a next of kin would be A, husband or wife. B, son or daughter. C, the father of the individual. If husband or wife not present, if son or daughter unavailable, father of the individual. D, the mother of the individual. They're not on the same level. Then E, brother or sister of the individual. F, grandparent. G, grandchild. H, uncle or aunt. I, nephew or niece. And so it's actually laid out there in order of priority, who gets the first say, and the first one would be husband or wife.
Just an aside, any reason is just a leftover from different times? Any reason why the father has a greater say over the mother, or?
I do not know. This act is from what? This act is from 2001. I think this was included from 2001. So it's not really that long, but that's how they do it. The father of the adult. Remember, these are adults, So the father of the adult would have priority over the mother of the adult.
Okay. All right. Interesting. And the spouse includes common law?
So the act is not clear on that. I don't like to give things out of ignorance, but I want to say possibly. I'll leave it at possibly. Possibly. I would have to look at how common law is treated and then try to correlate the two, but possibly.
Another issue is, let me add this one. No family members that we can identify, just someone brings them in, neighbor or whatever. We write them down as a next of kin. They say, oh, but I talk to them regularly, or I'm a friend of them for a few years. What are their? They say no family members come in to claim it.
They cannot consent. They're not in the list. They cannot consent. If you can't find anybody, you're probably going to have to ask the senior medical officer or the consultant to sign the consent.
So even if they say they're a long-time friend, know them for years, they're the neighbor, they know what their wishes are. They don't play a role legally.
They don't play a role, not according to the act, no. It must be a relative, and what it says here is if you can't find anybody, right? No next of kin, the SMO will give consent. You can't just create a next of kin.
All right, before we move on to the next question, can we repeat the list one more time in order?
All right, no problem. So A, husband or wife. B, son or daughter. C, father of the individual. D, mother of the individual. Then brother or sister. Grandparent. Grandchild. The uncle or the aunt. Then a nephew or the niece of the individual.
All right, thanks. And of course, these are all blood relatives, not friends.
Yes, all blood relatives.
Dr. Smith asks, how do we prevent breaching data protection standards when most work group chats are on WhatsApp? So they're on their personal devices and they're on WhatsApp, which is a personal app not issued by the government or by your organization.
So to protect you, I would say you'd need to move those chats. But you know what? I must say that WhatsApp always says that things are encrypted. Now, I'm just going to be very transparent here. Data Protection Act, I have not read that full act. I have not gone into it. I really can't advise on it very strongly with any level of confidence, right? So, but from my knowledge, really and truly, it means that you really need to keep personal information very secure. Now, what you need to do is make sure that your whatever you're doing is HIPAA compliant, and that helps to protect you. So you need to go and look into whatever it is that you're using and make sure that there's a certain level of compliance there and certification, and that's how you would protect yourself. So I'm not really sure if WhatsApp's data encryption, because they do say that it's end-to-end encryption. I'm not sure if that is. And furthermore, if it's on your personal device, you know, is your device password protected, so on and so forth. You know, do you have one of those antivirus, anti-whatever? Do you have a firewall on your phone? That kind of thing is going to come into play, because once that information gets out, the question is, what steps did you take to make sure that it was safe?
Does that also apply to recording? Should we save in our WhatsApp chats, or is that not
everything that would have had, remember, what protecting is the personal information of the individual. So everything that has personal information for that patient needs to be protected from public consumption or consumption by anybody who is not who they did not authorize to have access to it.
What if the person has power of attorney, right, but they're not related?
Right, so power of attorney is not something that gives you a blanket power of attorney over the person like that, right? So power of attorney can be very specific, so you really have to look at what that document says. It doesn't necessarily make you that person's next of kin.
Okay, so they would provide specific instructions on what powers.
Yes, the power of attorney could just be to sell this piece of land or to administer my business over there. You know what I mean? So it just really depends on what your power of attorney actually says.
All right, thank you. Are there any other questions?
Yes, I have a question.
Yes, go ahead, Dr. Mazi.
Make it an easy one.
I think it's easy, but it was a good presentation, Doc. I just have a quick question. So, you know that the majority of healthcare workers are employed by the regional health authorities. Does the Ministry of Health has the power or wherewithal to move a doctor from Zero to another region that's not directly employed to the Ministry of Health? So they're employed to the statutory body, but not directly to the Ministry of Health. That's part one. And part two is, does that statutory body have the power to move someone to another region?
All right, so I'm just going to be very clear. I really don't know. I would have to read what your contract says and all of this. I'm really not privy to those contractual arrangements and what exactly you guys have written there, right? But I must say, once the area is declared a disaster, if it is in that context that you're talking about, then once you're employed to any public body and you're a public officer, you can be called to anywhere to serve under the act.
Okay, because the debate is up now whether or not we are actually public officers or civil, or I don't know if you know about it, this whole thing that we're employed to the region and not to the ministry, so therefore technically not public servants. So that's why I was wondering if you know anything about that.
No, I don't know anything about it. It's not my particular area of interest. Those are more like employment issues, and I don't necessarily go into it. So unless somebody engages me specifically, like if JMDA asked me to do a presentation on it, would I really look into it? But no, I'm not sure. I really am not sure. I didn't look into it. No.
Yeah, man, thanks.
Going back to the issue of consent, Doc, what happens if the SMO doesn't wish to sign? So you have a procedure, it's at 3 o'clock in the morning. They say, sign on my behalf. right? Or I'll come in and I'll sign later, go ahead with the verbal consent. I'm not coming in at 3 o'clock in the morning. Are you still covered if something bad happens at 5 o'clock and then, you know, the fan goes wild at 6 o'clock and the SMO never gets the opportunity to sign?
Boy, you know, I would have to say you can't be covered. Okay, so everything is very we won't know unless you really take it to court and the judge decides based on the facts, right? But if something is written down in black and white and tells you to act a certain way and you go against it, you are now running a risk as to whether or not it will, you know, the other facts surrounding the case will help to protect you. So if I were you, I would certainly err on the side of caution and indicate, you know, of course, document why it is that you're moving on, that you got this verbal thing, consent form to be signed later, so on and so forth. But you run the risk of the SMO saying, I did not consent. That's why I didn't sign the consent. What are you going to do then? You see, it's a risk. I don't think that it would happen. I don't think it would happen. But I'm just saying, you have to know if you're going to do something outside of what you're told to do, and it's written in black and white, then you must now take that risk that you may take on that liability. If it becomes a he said, she said.
Okay. It's a difficult risk because under the circumstances, you're going to follow the SMO, you know. It's be difficult for a junior to say, well, I don't think I can trust you to sign in the morning. So I need you to get up out of bed.
Yes, and you're going to be balanced with the fact that maybe what is the other thing that you're not going to perform the procedure because they didn't sign it? I don't know. You have to, it's so fact specific, so you really have to make that decision for yourself, okay? They're not going to sign the consent, but they gave me verbal consent, you document it, and you may want to proceed with that. Or you have to ask yourself the question, was it really emergent, or could I just wait till the morning till them sign this consent? Why am I rushing this person and breaking procedure and everything? Unless it's really life or death. And then if it was life or death, you'd be protected under several different things, as I mentioned before, because life and death means you have to make a decision, consent or none.
Okay. All right, thank you. Dr. Edwards is asking or making a statement. I don't know if you want to add anything given what you've said. But the region isn't a silo. It was created by the Ministry of Health for governance, for example. So ultimately, isn't it the Ministry of Health the umbrella employer? Can they move you under those circumstances? Do you have anything to add?
I don't necessarily have anything to add because I really don't know what the exact arrangement is, but I do want to say that it is possible for a public body to have a somewhat kind of private entity, you know, administrating on their behalf, right? So conceptually, it would be possible for now those to be private employees. But I really don't know what is written in the black and white, so I can't tell you.
Okay. All right, thank you again. Are there any other questions before we let Doc go? All right, I want to thank you again for your very informative presentation. At this time, I'm going to ask if we can unmute or if Ms. Hay can unmute herself. You should have that ability now. You can make your presentation.
Yes, good morning, everyone. Abigail here from Apotex. So I posted the winners in the chat for question 1. It's Dana Lee Wilson, and I'm hoping I'm pronouncing it. I don't know, it's Tianette or Shawnette Allen. And then for question 2, Sandra Lee McFarlane and Mindy Fitz-Henley. So I've left a number in the chat that you can WhatsApp me and we can arrange for your prize to be delivered to you.
Do we know what the prize is for those
So
of us who didn't?
there's a choice of 5 items. So once you message me, I'll let you know, and then you can pick one of the 5 items.
All right, thanks.
Thank you so much as well.
All right, guys, we are 2/3 of the way through our morning session for the JMDA's conference, Annual Ethics and Health Conference. Our next presenter will be from our next presentation will be from Dr. Jordan Eaton, the trauma response on a spectrum. One moment. So Dr. Jordan Eaton is a consultant psychiatrist with extensive experience in acute and community mental health care. He's a graduate of the University of the West Indies, Mona, and completed his medical degree and specialist psychiatry training before serving as senior registrar at the Spanish Town Hospital, where he provides high-quality clinical leadership across multiple subspecialties. Dr. Eaton has contributed to research through CARIMENSA and has presented on key topics including HIV, COVID-19, and mental illness. He's also a co-author of published work on psychedelic psychotherapy in Jamaica with expertise in supportive psychotherapy, psychedelic-assisted care, and medical cannabis prescribing. Dr. Eaton remains committed to holistic and evidence-based mental health treatment. And I said he's a consultant psychiatrist, but when I say consultant, I mean that he's post-DM. He's the senior resident at Spanish Town Hospital. I want to thank you all for coming, and I want you all to give Dr. Eaton your attention as he presents his case to us.
Hi, morning, everybody. Can I just confirm that you're seeing the presentation and you can hear me?
Both are confirmed. We can see you loud and we can see the presentation and hear you loud and clear.
All right, fantastic. So good morning again, everybody. So I'll be presenting from disaster to diagnosis, stress and trauma after Hurricane Melissa. So to dive right in, I usually like to give us an outline of what we're going to discuss, the context of natural disasters, the connection between disasters and mental health, the real-world implications, the pathways from normal response to pathology, what we can do, and then we're going to summarize. So we're looking at about 43 slides, but a lot of it is filler like this. So context and framing of the issues. What are we talking about and why? In terms of natural disaster, according to the World Meteorological Organization 2021, extreme sudden events caused by environmental factors. It results in significant damage, economic loss, and loss of life. In the last 50 years, natural disasters occur almost daily with an average of 115 deaths and costs about $200 million in damages, and that's every day. I believe in data, so data. There is surprisingly an organization called the Emergency Events Database that tracks all global disasters. And their data, which is based up until 2023 from 1970, is showing that floods are the most frequently occurring natural disasters. We see that here. Storms, wildfires, heat waves, and droughts are on the rise, and we're seeing some of those here as well. The annual average US billion-dollar disasters has increased from 9 in 1980 to 2024 to 23 from 2019 to 2023. So you can see that there's a significant increase in the costs associated with these disasters. And hopefully there are no climate deniers on the call because I come with facts and figures. So you can see as time has progressed, the numbers are just going up across the board for all natural disasters pretty much. So let's put it into some more context in terms of economic costs. The National Oceanic Administration Association's National Centers for Environmental Information, which under the current government has stopped being updated since 2024. We press on. They're showing here severe storm and tropical cyclone accounting for 50.4% in terms of frequency with 203 events. And you can see tropical cyclone 67 with 16.6 frequency, but the total cost is 1.543 billion. Now, in terms of severe storm, they're considering tornado, hail, wheel damage. But what we're looking at is when you adjust for the consumer price index, the average cost for natural disasters, tropical cyclones like hurricanes within the US represent the biggest economic burden. And what we can see is that the distribution of damage from 1980 to 2024 is dominated by tropical cyclones. and they have the highest average cost, about 23 billion per event, US dollars. It is also going to have a significant knock-on effect, as we're going to discuss. So, disasters and mental health, how can the two be related? Why we're talking about it? Well, they're unexpected and uncontrollable events that have a major impact on a person's social, economic, personal, and well-being aspects of life. Nearly a third of disaster-affected people may experience a negative mental health consequence, such as PTSD, anxiety, depression, and others. Growing recognition of the importance of mental health assessment in disaster response strategies is being appreciated, and this is based on a paper by Hinoy and Brown in 2024. So we need to contextualize things. Following a disaster, most people are going to cope well, which is great. However, not everyone continues to function normally. Some affected individuals experience trauma related to disaster exposure, while others experience delayed onset of psychological impairment, and a small fraction of these can develop into more serious mental health conditions in the long run. But this isn't news, and this isn't new. I just included about 4 pieces of work here within the literature as early as a period of 1981 to 2001. And this was before I got bored. There were so many papers discussing the link between natural disasters and mental health that it's staggering. And what's the overall connection? Hinoy and Brown said it best in 2024. Natural calamities can have both short and long-term adverse effects on mental well-being as a consequence of changes owing to socioeconomic conditions, system disruption, social disruption, displacement, and financial loss. So let's consider the real-world implications, what we have seen or what we're going to see, because again, you're going to recognize that time plays a significant factor in the course of this presentation. Natural disasters to mental health concerns. There are several frameworks and models that have been developed in an effort to explain the multiple influences on a person's health and well-being. Converging evidence that well-being not only depends on personal factors such as your pre-existing mental health conditions, your pre-existing medical conditions, behaviors, attitudes, what we speak about in psychology and psychiatry a lot called our core beliefs and our negative thoughts, but it also is based on socio-environmental factors. And broadly speaking, there are 2 major pathways that are focused on. The stress reaction focused pathway, meaning distress-specific psychological outcomes of experience the disaster, such as depression, anxiety, PTSD. However, we can also see the psychosocial focus, meaning the role of social and environmental factors on mental health and the way disasters disrupt these factors and thus give rise to adverse well-being conditions. Now, I want to put a caveat that these are 2 broad frameworks and they're not standalone concepts. Rather that there is overlap and interplay between them because of the interactive nature of societal, environmental, and individual factors. There is a limitation in what the models are describing. However, the interconnected quality of social, environmental, and personal determinants to meaningful structure the wide-ranging impact of natural disaster on our general well-being. So, in terms of raw numbers and development of trauma and stress-related conditions, what are we looking at? A third of survivors are going to develop a psychiatric disorder, and that's 33.33%. So conservatively, if we're looking at 3,000 persons who are affected by this disaster, 1,000 persons, we are looking at development of a primary psychiatric disorder. 10 to 50% of these persons will develop PTSD. 5 to 54% can develop depression, and a whopping 2 to 84% can develop anxiety and related disorders. And these are 3 of the more common disorders. There are others that can present. And symptoms of PTSD or depression or even anxiety can persist for years. And look, we're still going. Children are highly susceptible to PTSD and anxiety symptoms. It makes sense. They do not have the neural development for adequate coping skills and the prefrontal cortex development for emotional regulation. People with pre-existing conditions or lower income are disproportionately affected by developing mental illness. And clearly, women usually more likely to develop symptoms than men. So, we're going to get into the meat of the matter. Trauma and stress-related disorders. And for the bulk of this section, we are going to be lifting directly from the Bible of Psychiatry, the DSM-5 TR. Why? Two reasons. One, we might be getting a new one soon, which is fun. But two, who better to explain it than the actual people who are defining it for this side of the world? So, trauma and stress-related disorders. Exposure to a traumatic event is listed explicitly as a diagnostic criteria. These include reactive attachment disorder, or RAD, disinhibited social engagement disorder, or DSED, post-traumatic stress disorder, PTSD, acute stress disorder, adjustment disorders, and prolonged grief disorders. And there is a note here that it is placed in close relation to surrounding chapters about anxiety disorders, obsessive compulsive disorders, and dissociative disorders because there is a link between, or there's a recognized association between the nature of these conditions developing in tandem. So what we are going to be doing is focusing specifically on the ones that are underlined: post-traumatic stress disorder, acute stress disorder, and a little bit about adjustment disorder. So, PTSD. If you're going to take anything away, I just want you to think trauma. And I know it looks like it's a strange way to spell it, but just trust me. I took my medication this morning. The ADHD is under control. Just bear with me. So, diagnostic criteria. First thing to note that this criteria applies to persons 6 years and older, including adults. Yes, there is a specific criteria for children under the age of 6. For the sake of brevity, I have not included in this presentation. And yes, I know it's strange that we're talking about PTSD rather than acute stress disorder, but trust the madness, there is a method to it, right? The first thing that you need to have, criterion A, exposure to an actual or threatened death, serious injury, or sexual violence in one or more of the following way. Within the context of disasters, directly experiencing it, witnessing in person the events, or you are in Kingston and you're learning about things that have happened to your family and or very close friends who are in affected regions. This can be actual death or threatened death of a family member or a friend. And it can be, or the events rather, must be violent or accidental. And experiencing repeated or extreme exposure to adverse details of the traumatic event. So imagine us, for example, going into these trauma areas over and over and over again. And I would like to put the caveat here, that's why I will not be showing any pictures of any of the trauma affected areas. I will just be mentioning one slide towards the end. What is important in terms of post-traumatic stress disorder is the development of the symptoms following the exposure to the traumatic events. The clinical presentation varies. Some persons may have fear-based, emotional re-experiencing and behavioral symptoms. Others may have mood symptoms, dysphoric mood symptoms or negative cognitions, or you may have a predominance of dissociative symptoms or reliving, reimagining symptoms. You can have the same condition, but see different presentations of the conditions. So, criterion A, we must have exposure to trauma. Next. Criterion B, one or more of the following intrusion symptoms. So you're thinking of recurrent, intrusive, distressing memories, recurrent, distressing dreams, dissociative reactions such as flashbacks, intense, prolonged psychological distress to exposure, to internal or external cues or symbols that represent aspects of the trauma. So, for example, someone may be in the middle of hearing high wind outside, which is triggering them as a trauma response because of the high winds that happened during the hurricane. Next, criterion C, There's persistent avoidance of stimuli associated with the traumatic event beginning after the traumatic event has occurred. So you're looking at avoidance of or efforts to avoid memories, thoughts, feelings that are associated with the event. You are also looking at avoidance of efforts to avoid external reminder, people, places, or things that can be associated with these traumatic memories. Criterion D, negative alterations in cognition or mood. You require 2 of these. You cannot remember important aspects of the trauma. There are exaggerated or persistent negative beliefs. So, the world is completely dangerous. My whole nervous system is permanently ruined. You have persistent, distorted cognitions about the cause or consequences of the traumatic event. So, for example, people who have been saying, we brought this down on ourselves or this was man-made, it infers a level of victimization that is not based in reality, but let's not dwell. Persistent negative emotional states such as fear, horror, anger, guilt, or shame, diminished interest in activities for pleasure or participation in activities, and a feeling of detachment. No, that's the hard part over. Criterion E is the arousal or anxiety type symptoms, and again, you need 2. Irritability, reckless or self-destructive, hypervigilance, exaggerated startled response, sleeping problems, or problems with concentration. It must be happening for a month, and the rest of it is it must be causing clinically significant distress to affect the person's level of function. I've included, just for completion, the specifiers in terms of depersonalization and derealization. Don't worry too much about that. What you can consider is delayed expression, meaning that the beginning of the symptomatology onset is up to 6 months after the presentation of the initial traumatic event. And it should be noted that, again, you need the duration of 1 month in symptoms. So acute stress disorder, and the question becomes whether I do post-traumatic and then acute rather than acute versus post-traumatic. Because the symptoms associated with acute stress disorder are restricted to 3 days or up to a month following the traumatic exposure. So from a timeline perspective, trauma exposure is 0.0. Days 3 to 1 month would represent acute stress, and 1 month and beyond is post-traumatic stress. The reason we have flipped the order is because the essential features of acute stress disorder are the same as those of post-traumatic stress disorder criterions once you are having the exposure to the symptoms. What am I saying? You have exposure just like criterion A for post-traumatic stress, meaning it is you or someone that you are close to, or you're witnessing firsthand the effects, or you are having some close association with a person who is laboring under the effects of a traumatic or near-death experience. Within 3 days to 1 month, if you have any of these 9 of these 14 symptoms, you have met the diagnostic criteria for acute stress disorder. And these 14 symptoms are the exact same symptoms as PTSD. So it's just picking whichever symptoms. And that is how you're saying it is acute stress disorder, because it's causing clinically significant distress or impairment in social, occupational, or other areas in functioning. And again, must not be able to be due to anything else. So that's a lot of information. Let's make it simple. When you're thinking about trauma as a whole, specifically PTSD, the first thing you need to have: T, traumatic exposure; R, reliving, re-experiencing, reimagining, such as your nightmares or your flashbacks. A, avoidance, people, places, things, thoughts, any reminders of the traumatic events. The U is small because it's unpleasant alteration in mood or cognition, and you need 2 of them. M, a month or longer in duration for PTSD. And A, anxiety or arousal symptoms, and you need 2 of them. That's why the 2 that are common letters are common, so you can remember which two you need two of. So we take a breath, and we discuss adjustment disorders. Not really what we are used to seeing, but still within the realm of possibility. Excessive, maladaptive, emotional, or behavioral reactions to a specific, identifiable trigger or stressor. It is behavioral symptoms that are in response to the event, and the event can be, for example, the termination of a romantic relationship, or it can be multiple stressors that are recurrent or running concurrently. So, for example, the social, occupational, interpersonal disturbances that can come post-disaster can be considered recurrent and or continuous stressors or traumatic events. You have the development of the condition within 3 months of the onset of the stressor. So if the hurricane occurred in October, October to November, November to December, December to January, you are in the window for adjustment disorder. The symptoms or behaviors are clinically significant, such as distress that is out of proportion or impairment in functioning. Criterion C, the stress-related disturbance does not meet the criteria for example, PTSD or acute stress disorder. So this is what you are going to be using in the event of it looks like acute stress, it looks like PTSD, but because of either time or because of the diagnostic criteria in terms of symptoms, it can't neatly be diagnosed. Adjustment disorder still captures a possible diagnosis. And here is why. You can have depressed mood, anxiety, mixed anxiety and depression, disturbance of conduct, such as with children, and you can have mixed disturbance of emotions and conduct. And you can also just have unspecified. So, what do we do? Because hopefully by now everyone is sufficiently concerned. The next steps, well, you're doing one now, being in a session like this and paying attention. Step 2, recognizing the signs and getting comfortable speaking to patients about them. And I say to specifically, not at. Don't forget that this applies to our patients as well as ourselves as first-line responders. We can get elements of trauma and stress response, such as PTSD. And those of you who know me know I love a screening tool because it's objective, it's easy, and when all else fails and you don't want to have to think too much, or because you cannot think too much, you try something tried and true. Those of you who know me and hear my talks about depression and anxiety are tired of hearing about this, are tired of seeing it, and here we are again, the PHQ-9 and the GAD-7. Reliable, tried, and true. Patient Health Questionnaire 9 is a screening tool for depression. 9 questions, 3 possible severities for a total of 27. Each one adds up, and the score determines if you could be at risk for mild, moderate severe, or severe depression and warrant further screening. Similarly, for the GAD-7, 7 symptoms of anxiety disorders, 3 questions, total of 21, still gives you an answer at the end as to severity. So we can screen effectively. Then there is the PC-PTSD-5. It is the primary care PTSD screen for DSM-5. 5-item yes/no screening tool specifically designed for primary care. It screens for trauma exposure, followed by symptoms in the past month, such as nightmares, avoidance, detachment, hyperarousal. And if this patient scores more than 3, it indicates probable PTSD and requires further assessment. And this is not the end of it. There are still others. The PCL-5 is a 20-step questionnaire. The IESR 22-item measure, subjective distress caused by traumatic event. The acute stress disorder scale can be used in the early weeks to identify those at higher risk for PTSD. Even for depression and anxiety, you don't have to use the PHQ-9. You can use the PHQ-2 or the PHQ-15. You can use the Beck's Depression Inventory. You can use the Hamilton Depression Inventory. The list goes on. So taking a step back from all of this, the question that I asked myself was, all right, cool. So we know what we're looking for. We know how to diagnose this. We got an idea of what we're doing. What are our treatment intervention options? And is there anything that has been put out recently about treatment? And wouldn't you know it? A paper was put out in August 2025, published in the Psychiatric Times Online by a psychiatrist, assessing and treatment of PTSD in the wake of natural disasters. Lessons from Katrina to today. And I like when I find things that fit my narrative quite nicely. What are the general guideline recommendations? First line, surprisingly, is not medication. Weird for psychiatrists to say, I know. But first line treatment, trauma-focused psychotherapies, cognitive processing therapy, prolonged exposure therapy, eye movement desensitization and reprogramming, or EMDR. All of them have been shown to have efficacy in disaster-exposed population when delivered in both individual and group formats, and can be or may need to be adjusted for cultural and contextual needs. Okay, I take your point. We may not have access to that. Fair. Option 2, however, is then pharmacotherapy, because SSRIs such as sertraline and paroxetine and fluoxetine remain treatments approved by the FDA for PTSD and are effective as well for addressing comorbid anxiety and depression. And they're particularly helpful when psychotherapy is not immediately available. So there is a role for medication. Also, we may not see it so much in the island, but just for general edification, prazosin can be beneficial in treating trauma-related nightmares and improving sleep, though recent studies suggest variable efficacy and therefore its benefits may be more modest than previously thought. What about a third option? Sure. Community and group interventions. Psychological first aid, critical. Focuses on stabilizing and supporting survivors in the immediate aftermath without pathologizing normal stress reactions. And I pause here because, again, we need to acknowledge and recognize that, yes, you can develop the rapid onset of multiple symptoms very quickly, such as 3 days after the event, that is causing clinically significant distress that is meeting the diagnostic criteria for a condition such as acute stress disorder. That being said, how would you feel if someone had just cut off your leg for diabetes, a leg that you had been attached to, literally and figuratively, for the last 30 years? You know it has to come off, but you are now waking up day 2 post-op, and you feel kind of sad? Do you think you'd want someone from psychiatry or psychology to be coming to talk to you right after asking you personal questions? Or would you want maybe your doctors to look at you and say, hey, it's okay. It's normal to feel this way. We can help you to talk you through it. And if it's still not helping, we can get some specialist help if you want. And this applies across the board. Patients are allowed to be sad. We have to give patients a chance for their natural coping mechanisms to kick in. So we need to encourage them, and we need to help individuals to build coping skills and reestablish a sense of control. That in and of itself can help to prevent the development in the early stages, long-term complications of trauma. When in doubt, validate. What you're experiencing is common after disaster. Normalize help seeking, encourage routine, encourage sleep hygiene, and encourage social connection. Treat comorbid medical conditions aggressively because high stress levels can interfere with some chronic conditions such as diabetes and/or hypertension. Do not minimize. Please. Others had it worse is one of the least helpful statements and possibly traumatizing statements that can be said, especially from a healthcare provider. Do not force disclosure. You can re-traumatize the patient or the client by forcing them to talk about these things before they are ready. Do not overly sedate or rely on benzodiazepines. It should be minimal doses, if any at all. And I'm talking alprazolam 0.25 milligrams, maybe only at night for 10 days. It is important that we recognize phases in recovery and that things may be going well, but disillusionment does come, and everyone is vulnerable and at risk. It is important to pace and rest. Recovery is short, medium, and long term, and reconstruction processes can take years. But there is still a glimmer of hope. Courtesy of Dr. Delahaye, who has been working with University of the West Indies and University Hospital to mobilize responses in collaboration with other teams. We have some work ahead of us, but we are still doing some work. This is just a snippet of some of the missions that were done recently. And again, I chose these because I'm biased. Some of them focused on psychiatric patients, and it makes me kind of feel good. Which brings me to this slide. If you don't document it, it wasn't done. These were some of their missions that they carried out while on site. And what inadvertently happened is that persons who were there for mental health reasons or providing mental health support somehow all ended up in yellow. And it was now like, oh, that's a thing. Let's make this a thing. So it made it so very easy when you're looking into a crowd to be able to look and see, oh, I know that that volunteer specialized for mental health. If I have a problem or I need to refer someone, that's my first point of contact. And it's great. Shameless plug. Great organizations doing great work, and they're free. And you can still volunteer your time and services if you can manage it. Even if you're not comfortable with psych is usually within reach to help and offer needs. So we can talk about the powerful virtual classroom that offers a standardized and recognized psychological first aid course that you can do at your own pace, and you get a nice certificate after it, so you learn the do's and don'ts. You can also do, if you're so interested, the Mental Health Gap Action Program, which is basically empowering non-psychiatrists to see and recognize common psychiatric conditions and understand first steps in interventions and when the need for urgent referral comes up. Also, the Caribbean Technical Assistance and Education Center for Health, CTEC, also does mental health sessions, and they also offer mental health support for persons who are healthcare workers who may not want to access services within the healthcare community locally. So I'm just over 30 minutes, but I'm about to finish up. So, summary. I'd like to stop talking and we can all go home. Can I fit 39 slides into 2? Absolutely. Here is the first one. Number 1, natural disasters are in fact natural, but frequency is increasing and the associated costs are increasing. Hence and therefore, we are going to be seeing more of these events in the future. After natural disasters, everyone is at risk, including care providers. It is normal to have a stress response in the acute stage and should be validated. Screen for depression, anxiety, and trauma. Normalize getting help, even among the helpers. And when in doubt, refer early. Now, I've been speaking for 30 minutes. And I remember a lecture I got in med school from Dr. Edwards, who said, Jordan, you've lost your entire class at this junction. What you need is a summary slide that tells everybody what they need to look out for and how quickly they can do it. Okay, here's what you can do in a simple 10-minute consultation. Step 1, identify the context in the first minute or 2. Post-hurricane exposure. Are we looking at displacement or loss? Or are we looking for sleep disturbance? That's easy. Second, in the next 2 to 3 minutes, you screen for trauma, intrusive memories or nightmares, avoidance of reminders, hyperarousal or insomnia. If 2 of those or more are positive, you're looking like trauma. 3, you're going to classify it. Now, if you're looking at less than 4 weeks, normal. Do not panic. If it's 3 days to 1 month, acute stress disorder. If it's greater than a month, you're looking at post-traumatic stress disorder. And the key message, if symptoms impair functioning or persist for more than 4 weeks, so you can still be in the 2-week period where it's quote unquote normal stress, but your function is impaired, this is a time to refer. The immediate management is you validate the response, you promote routine and sleep, and you avoid benzos unless it's absolutely necessary. And urgent referral. Is there suicidal ideation, psychosis, or dissociation? Is this person unable to care for themselves, or are we looking at severe substance misuse? Call the psych team in. we can help you, we can get it sorted. These are some of my references. And at this point, does anybody have any questions for me?
I want to thank you, Dr. Eaton, for a very good presentation and a very, very excellent summary slide. Want you guys to put your questions for Dr. Eaton in the chat. We're going to have brief messages from our gold sponsor, Venta, and our silver sponsor, Carrigen. And then we'll pick back up with Dr. Eaton right after. So we'll just head on straight into our messages and then come back.
By Aventa. Aventa evokes the word advance, reflecting our commitment to innovation and improving health across the region. At the heart of our logo is a spark, symbolizing the convergence of human values and science. Because at Aventa, customers and patients are always at the center of what we do. So what's changing? Our pharmaceutical distribution companies in Jamaica, Barbados, Trinidad and Tobago will transition to this new name as part of our broader rebranding. Our retail operations at Super Farm, along with Linda's Bakery and Presto, M Pharmacy and Collins Pharmacy will retain their names, as well as our manufacturing companies Ingersoll and Carlisle Laboratories. Looking ahead, this rebranding strengthens our identity as one unified group, making it easier for us to grow, innovate, and serve our communities. Together, we're advancing health, enhancing lives. Welcome to Aventa.
Good day, this is Health 2000 Canada, H2K, a generic pharmaceutical company serving Jamaica since 1999, distributed by Aventa Jamaica. We provide affordable over-the-counter products and prescription drugs manufactured with the highest standards of safety and efficacy in mind. Here are a few product reminders. When you have wet, dry, or any cough, use Dawa Cough. An excellent mucus expectorant and bronchodilator in one. Dawa Cough contains just 2 mg salbutamol, 4 mg bromhexine, 100 mg guaifenesin, and 1 mg menthol in one great tasting syrup. Dawa Cough is excellent and effective in the treatment of reversible bronchospasm in bronchial asthma, bronchitis, pulmonary emphysema, or just in the symptomatic relief of coughs and catarrh in flus, cold, and mild throat infections, and any chesty coughs. The typical dose for Dawa Cough is 2.5 ml 1 to 3 times daily for children 2 to 6 years, 5 ml 1 to 3 times daily for children 6 to 12 years, 5 to 10 ml 1 to 3 times daily for children 12 years and up, and for adults 10 ml 3 to 4 times daily. H2K esomeprazole 40 mg tablets, the cost-effective one dose for heartburn, acid reflux, and GERD that lasts 24 hours, providing faster symptom relief within 4 weeks than other PPIs in its drug class. H2K esomeprazole 40 mg tablets treats acid reflux and GERD, H. pylori infections, heals erosive esophagitis, and reduces risk of ulcers from NSAIDs or Zollinger-Ellison syndrome. The dosing and directions for H2K esomeprazole 40 mg is dependent on the disease or condition diagnosed. The typical dosing is once per day, preferably before the evening meal. Tablets are to be swallowed whole and not chewed or crushed. For children up to 18 years of age, the use and dose must be determined. H2K loratadine 5 mg per 5 ml of oral suspension 100 ml and 10 mg tablets. Loratadine provides allergy relief without sedation for indoor, outdoor, and seasonal allergies, as well as rapid relief from the itching and redness caused by hives. It acts within 20 minutes to 1 hour and lasts for 24 hours. Did you know that H2K is a sole provider of loratadine syrup here in Jamaica? Yes, we are. Available in pharmacies island-wide. Discover natural ways to improve your skin and heal wounds or irritation with our herbal Boro Total Neem Cream. The ingredients in Boro Total are neem, aloe vera, sesame seed oil, asoka, licorice, and zinc. Boro Total is effective and useful when treating nappy rash, dry cracked nipples, blisters and burns, acne, insect bites, and much more. Boro Total Neem Cream is locally recognized and effective for the diabetic foot, that thin, dry, papery skin that is prone to ulcers forming. For a herbal alternative for wounds and skin infections, use Boro Total Neem Cream. You're gonna love it. Vitamax Multivitamin and Mineral Syrup. Vitamax provides 15 essential vitamins, minerals, and trace elements, making it one of the most complete preparation in one spoonful. Vitamax contains 75 milligrams of L-lysine, an essential amino acid important for boosting your appetite, boosting fat loss, and helps to reduce fine lines and wrinkles. Vitamax sweet pineapple flavor without added sugar is a hit with everyone. Good. Safe for diabetics. Vitamax was specially designed for optimal performance and overall health. A great supplement to take during pregnancy, lactation, calcium deficiency or vitamin deficiency, and when recovering from an illness. So it's a thumbs up for Vitamax, especially since it now costs 50% less, making it much more affordable for everyone. Team H2K thanks you for inviting us to partner with you and asks that you support us by writing H2K before the drug name on your prescriptions. All our products are available in pharmacies island-wide. Have a wonderful week ahead.
Genomind, personalized mental health through genetics. Mental health is biologically complex. Genomind uses genetic testing to move beyond trial and error, empowering clinicians with evidence-based insights to choose the most effective medications. Our testing evaluates how a patient's genes impact drug metabolism and response, leading to more confident prescribing and enhanced patient trust. While environment and therapy still matter, Genomind brings the power of genetics to your treatment plan. Genomind, empowering clinicians, improving lives, brought to you by Caribbean Genetics.
All right, good afternoon. So to finish up our morning session, we'll just have our question and answer period with Dr. Eaton. Dr. Eaton, just a quick thing. Could you repost that summary slide at the end?
Sure. So actually what's going to happen, Leighton, is I actually prepared a handout front and back, a PDF document, and it covers everything. So it covers, basically, it's an entire summary of the entire presentation, including that 10-minute slide. So that is supposed to be distributed to everyone at the end of it.
Thank you. Prepared as always. Sure, but just put it back up if you can. It's for those
All
who
right,
want
sure.
to
One
take a
second, I can
snapshot.
find it.
All right, as you put it up, let me just ask somewhat of a silly question, right? Why should we bother with all of this? The healthcare workers, you know, they're gonna go through a stressful period, but pop it out, right? And why should all of this screening and so on? What's the importance here?
Are you asking for the benefit for us, or as benefit for our patients, or
For
both?
patients, whoever. What's the benefit of why we can't just tough it out? And did we do all of this in Hurricane Gilbert? Do we need to do this now?
All right, cool. Fair questions are fair. Why care about mental health at all? Okay, sure. So when places eventually start functioning again, we are still going to run into a worse problem that we had with COVID. So I don't know if anybody actually remembers that, but I'm pretty sure I have PTSD. And I still have nightmares about getting COVID infections. Everything was on lockdown. There was no life. We were all going through it. We were all sad. We were all depressed. It's affected us. People were crashing out left, right, and center. And some people were having their 13th reason why. So as a clinician, I know that if my patient has a chronic illness or doesn't even have a chronic illness, the chance of them having a chronic illness or worsening of their underlying chronic illness goes up as a result of untreated mental health conditions like depression, anxiety, PTSD, pathological stress responses, etc. But sure, say we're not really focused on our patients. Say we're more focused on ourselves, which again, fair, physician, heal thyself. But it's just that. How can you heal yourself if you are burnt to a crisp? How can you heal yourself if you can barely think straight? If you can barely function to get out of bed and get to work? And if you're thinking, hey, maybe it would be easier to just take off the PPE in the middle of the COVID ward. I mean, I would get 2 weeks off work. I don't think I'd die. I'd probably just be sick or put in isolation. Yeah, man, I've heard it. But I guess that's quote unquote normal or should be contextualized as normal. I'm not sure. But I think personally, it may help, especially since our health sector is kind of popping down right now and we don't need any more doctors dropping like flies. So I feel like screening for mental illness and treating mental health conditions benefits everybody? Question sign or interrobang.
All right. You mentioned limiting the use of benzos. What do you recommend instead?
So it depends on what we're treating. You can use short courses of benzos. So, and I do mean short, like you are using 0.25 milligrams. I know a lot of people believe that you need 0.5 milligrams and above to sleep. I promise you, guys, 95% of your patients, 0.25 milligrams at Xanax at night. Great. That's all they need to just take them into sleep. They will sleep through the night. And you give them for maybe a week. No 2, 3, 4, because then you're running the risk of benzodiazepine use disorder. And what invariably happens is that the patient at week 4 of being on this benzo is not sleeping anymore. So it has to go from 0.25 milligrams to 0.5. And then another 2 weeks after that, it's not sleeping anymore. And then has to go to 1. And then finally gets help, the stressors are relieved, whatever. And she's like, oh, great. I don't need this anymore. I'm going to be sleeping better, and then can't sleep, gets sicker, and then puts herself at benzodiazepine withdrawal disorder, which pretty annoying to treat since it requires you to be in 3 weeks in hospital. It's useful in very short bursts, very low doses for safety, for efficacy, for patient well-being. Also, it can be seen in some patients as a crutch, preventing them from actually connecting with the emotions and having a normal and healthy stress response, or blunting it artificially so they can have a delayed expression of their symptomatology that drags out over time rather than just working through it and actually feeling better. So those are a couple of things. Plus, benzos as a whole are just a temporizing measure. If you're really concerned about like depression, anxiety, PTSD, there are better medication options like the fluoxetine, like the sertraline, that are safe to use long-term and can help to correct some of those underlying sleep, attention, concentration, appetite problems that you can see with the PTSD depression spectrum.
They're safe to use long-term, but short-term, you're recommending benzos, or is it that short-term we can use these drugs as well?
Short-term, I would suggest use a benzo if you're in desperate need, and no more than 5 to 7 days.
Okay.
If you're concerned about depression, PTSD, anxiety, sertraline, paroxetine, fluoxetine, great medications, tried, true, stable, offer symptom improvement within 2 weeks.
What
But
about-
again, first line treatment, talk therapy.
What about certain symptoms like insomnia, right? Is there any alternative to the benzos for insomnia?
DPH can be helpful. Low doses of CPZ, which you have to be careful for because it can cause lowering of the blood pressure as well. So maybe 25 to 50 milligrams, and you gauge a response. Zopiclone, a half to 1 tablet at night, can be useful as well, but it does come with a bitter taste in the mouth in the morning, and it cannot be used. It should not be used for longer than 2 weeks because of the risk of hepatic injury.
Okay. We have Dr. Fitzgerald commenting Zopiclone 3.75 milligrams up to 7 milligrams a dose, just to add further context.
Right. So a half tablet to 1 tablet. That's Mindy.
If we wanted to refer patients to you, right, privately, how would we be able to do that, or to any psychiatrists who might be able to assist us?
Sure. So you can get in touch with the Jamaica Psychiatric Association. We have an online presence. Our president is Dr. Kazaro, who is going to be presenting shortly after me. So can reach out to that. Me specifically, if you want, you can contact me via email. Usually is the easiest, jordan876@gmail.com.
One final question from me. I see all the pictures of the groups, the medical groups that went out, and the schedule that was posted for all the outreach efforts. I think that's a great thing that the health sector has been doing. I just want to know, how has it been in terms of those patients with pre-existing mental illness, the patients with schizophrenia and bipolar disorders?
So it's been very, very challenging because a lot of those patients are being treated in a general medical hospital, on a medical ward, or in emergency room. But the problem is we have a shortage of persons who are trained in psychiatry. So patients are restrained getting medication at subtherapeutic doses once a day because people just aren't sure what to give. So it has resulted in some protracted admissions to hospital, something that the regions and the psychiatric associations are trying to work through in terms of mobilization of staff. But it's been challenging. Thankfully, on some of the missions that have happened, we have had people who have been able to tend to some of those psychiatric patients. So we're working on it. But it's been a challenge.
All right, thank you. I want you guys to continue the good work. His email address was listed in the group, and the Jamaica Psychiatric Association has a list of all their psychiatrists on the website. I assume we can Google to get access to that website.
Or if not, you can just email me and I can share it with you guys.
All right. All right, thank you very much. That is our last presentation of session 1. We will be going into an infomercial by CIBC Caribbean, and then we will begin session 2 with our moderator, Dr. Lashani Lindo. I have been your moderator for this morning. I am Dr. Leighton Samuels. I want to thank you all for attending our first session, and have a good day.
The future finds us faster than we think. But with CIBC Caribbean on your side, you'll be ready for all of it. That's how we've served Jamaica for over 100 years, with industry-leading digital capabilities and innovative solutions. And it's how we'll do it for 100 more. That's the power. Banking better together. Come, see what that looks like for you at CIBC. Ambitions made real.
Indus Life Sciences Private Limited, transforming human lives globally.
Good afternoon, everyone. So I want to thank you for staying with us to this point. We're going into our second session, and I will be your moderator for the second part of our conference. I am Dr. Jubilee Brown Service, and I'm the first Vice President for the Jamaica Medical Doctors Association, as well as the conference manager for this year. So I want to confirm with you that you will have 5 CME hours available once you pay the nominal fee. Attendance is free, but once you pay the nominal fee, you'll be entitled to a CME certificate where you will get 3 ethics and 2 mental health credits. Our sponsors for today, our platinum sponsors are the Medical Protection Society, Indus Life Sciences. Our gold sponsors are CariMed, Arista Pharma, Apex Radiology. Our silver sponsors are Caribbean Genetics, CIBC First Caribbean, Magif, NCB, and another gold sponsor is Aventa. Now, we have been posting in the chat how you can join the JMDA and how you can pay for your CME certificates. So you can look in the chat for the links for both of those tasks. And I want to ask you to type in the comment section if you have any questions for our speakers. And then, as you know, a number of us will go through and we will highlight your questions to ask the speaker at the end of their presentations. And you are free to make general comments in the chat. You don't need to post your email in the chat to get your CME. Once you have registered, then we will have the registrants list on the back end, and we'll be able to provide you with the CME. We ask for 7 working days to send you your CME certificate. And the recording of the conference and payment link will be available until February 28th, 2026. And so you will have access to it if it is that you weren't able to stay for the entirety of the conference, or if you know someone who would like to join after today. So we are now going to take the video from the Indus, a video presentation from Indus, before we move into our first speaker for the second session.
Indus Life Sciences Private Limited, transforming human lives globally.
From Indus Life Sciences. So greetings to everyone. And you know, last year was a very tough year for all of us, but we are resilient people. Stay strong, rise harder. Together we can rebuild Jamaica. And after Melissa, we reached out many of the communities that was affected, specifically in St. Elizabeth, Westmoreland, as well as St. James, and even Trelawney. As you could see in the screen, we donated a lot of medications for those needy people. We also joined hands with many organizations. As you could see, we donated almost 300 scrubs through University Hospital of West Indies to Cornwall Hospital, Noel Holmes Hospital, Falmouth Hospital. Also joined hands with Pharmaceutical Society of Jamaica, PSJ, and we donated medications. And with University of West Indies, also many private doctors did reach us, and we donated good amount of medications, and we are going to continue to do so till the communities get back to normalcy. So with this, I just go to our branch, Indus Life Sciences. I'm pretty sure everybody know Indus. We are out of 3 Carifta Avenue, Kingston 11. INDUS, Indus, that means Indus, that is Indus. So some of our popular brands, which is across Caribbean, I could say is very popular. One is a vaginal insert, formulation of antibacterial metronidazole with yeast infection. For yeast infection, miconazole. The first formulation, a gel formulation, that also comes with 5 applicators. That makes it hygiene. The uniqueness of this drug, Dresvi, is that this combination is in a gel formulation, and the technology of the gel formulation is very interesting. It is called a CPM technology. CPM stands for carbomeric polymeric gel technology. The benefit of this technology is that when the patient inserts the Dresvi gel with the help of the applicator, the gel spreads and sticks to the vaginal wall for longer duration, thereby effectively eradicates the infection better. That's the benefit of Dresvi. And it still cost in Jamaica less than $2,000 for 5 nights course. That's our Dresvi. And as I mentioned, this is a CPM technology. Dresvi is available across Caribbean, not only in Jamaica, most other Caribbean countries. And next brand, which I like to remind you, is our Capsitop, which is basically a pain gel. But the uniqueness of this gel is that this has 3 active ingredients, namely the capsaicin, diclofenac, and levomenthol, as well as methyl salicylate. Interesting about Capsitop gel, these ingredients work in different pathways to deplete pain. The capsaicin depletes pain by inhibiting the pain mediator, the triggering factor, substance P. And diclofenac depletes pain by inhibiting the triggering factor, prostaglandin. And methyl salicylate also depletes or inhibits pain by blocking the mediators IL-1, IL-2, IL-6. So that's why we call Capsitop as a SWAT specialist. They specialize in different, mediators, and they block the pain. When the pain is moderate to severe, Capsitop is a better pain gel, and this is over the counter down in Jamaica and most of the Caribbean countries. And where you can recommend, some may say back pain, some may say neck pain, some may say joint pain. The honest answer is all the above pain. Capsitop can be recommended. Being capsaicin is one of the ingredients, we have to take caution not to rub aggressively. A gentle spread is sufficient. Of course, you have to wash hands with soap. The other one interesting product we have is a pain spray, ready spray. This is all natural ingredients, eucalyptus, turpentine, methyl salicylate, and menthol. This is not a gel, this is a spray. And this is again over the counter. Being all natural ingredients is very safe too. Comes in 2 containers, 43 ml, which is very ideal for your travel kit, and also 150 ml. They respectively cost 350 Jamaican dollars and 700 Jamaican dollars to the patient. And we have a nice tagline, being all natural. We just coined a tagline saying, ready spray is powerful like a real beer, safe like a teddy bear. That's our red heat spray. And we have another drug, which is pregabalin, norabalin. Here I like to just communicate, we have dropped down the price heavily. Our price per month of 30 pills of 75 milligram is just cost 2075. This is the first brand of pregabalin available at this price. Unimaginably affordable compared to other brands, which may cost 3 to 4 times more per month. This is just 2075. And even after pharmacy markup, as you could see here, the pharmacy may dispense at 3,394 and the NHF subsidize 3,225. That's the benefit of norabalin, the most affordable pregabalin in Jamaica. And for allergy, we have our antihistamine Fexil, fexofenadine, 120, 180 is available. Non-sedative, second generation antihistamine. Fexil, fix it with Fexil. Fix your allergy with Fexil. And for productive wheezing, asthmatic cough, we have a better formula for better results and also offers better economy. That's our Viscofase, ambroxyl, guaifenesin, salbutamol is a combination. Viscofase offers you the surfactant action in ambroxyl, reduces the surface tension, improves the action of antibiotic that is co-prescribed. We are on cough and cold season. Please remember to prescribe Viscofase for your patient with chesty cough. Viscofase. Here, highlighting point is that the salbutamol, the bronchodilator, is 2 mg per each 5 ml. So unlike other cough expectorant, you don't have to give 10 ml for adults. Even if you recommend 5 ml for adult 3 times a day, they get the benefit like 10 ml with other brands. So the benefit is that 100 ml will last long for 7 days. No need to buy 2 bottles. That's the benefit of Viscofase. And for patients who suffer from heartburn, hyperacidity, gastritis, flatulence, reflux, and ulcer, the best antacid in Caribbean, the 3rd generation antacid, new gel is available. The unique antacid with alginic acid benefit. And the alginic acid offers this raft, as you could see in the screen. The benefit of this alginate raft, it prevents GERD, acid reflux. Thereby, it stops heartburn. Just a small clip that explains how effectively it works. The person takes new gel here, as you could see here. Just within 4 minutes, the alginate raft is formed. And this alginate raft blocks the stomach content moving from stomach into the food pipe. The action continues literally for 5 hours till the person is ready for next meal. So that means when the person is on new gel, no acid reflux, no heartburn. Of course, new gel also has acid neutralizing medication, and it has dimethicone that relieves gas. This is a combination of new gel, as you could see here. New gel is safe in pregnancy, all trimesters, safe in children less than 10 years. It's over the counter in Jamaica. We have the one with oxytocin that relieves pain. That is new gel O is available. Oxytocin is basically similar action like lidocaine. It relieves gastritis pain instantly. And we are the first company in Caribbean has rolled out new gel and new gel O in on-the-go sachets, liquid inside the sachets. No need to mix with water, tear it and drink it. The cost just costs 40 to 50 Jamaican dollar per sachet. That's also available. New gel and new gel O, both of them are over the counter.
Become fast like how new gel relieves heartburn. This movie need food and some good wine. Good thing new gel antacid relief lasts longer than that late night snack. New gel relieves acidity in as little as 5 minutes. Give me new gel antacid. Become fast. New gel antacid is sugar-free, safe for all, and the only antacid with liquid on-the-go sachets. New gel antacid. Quick and fast, relief that lasts.
Oh, thank you very much. So you know what is quick and fast? It's new gel.